view.
Thank you, Dr. Saima. I will share my screen.
Yes, Dr. Shahzad, you can show your screen now.
Okay. Dr. Ahmed, the slides are clear and my voice is okay?
Yes, the slide is clear and your voice is clear, Doctor.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah to all the participants of this course. And thank you, Dr. Saima. Thank you, Dr. Ahmed Kohel and Dr. Ahmed Madi for introduction and especially arrangement of this course. And my topic will start that COVID-19, especially related with pregnant women, and what are the case definition and how are the pathways that if the patients are being to presented in the emergency department, then how they are moving and with which kind of precautions we are taking. The contents of my course will have an introduction of the COVID-19, its epidemiology and modes of transmission. So the close contacts and healthcare workers, how they can be prevented from a COVID patient, and how the pregnant ladies and our patients can be prevented from this coronavirus contamination. What are the signs and symptoms, and what is the case definition and specifically the pathways? And then in the end, frequently asked questions about the pregnant ladies, those who are planning or those are pregnant already. I hope at the end of the session, participants will be able to have an introduction about COVID-19. They can enlist the signs and symptoms of coronavirus, and they can explain the case definition of COVID-19, that which patients we are going to suspect, which patients are going to fulfill the interim guidelines to be suspicion of COVID-19 or confirmed cases of COVID-19. We will explain the pathways, that there are certain pathways like patients coming to the central hospital in the emergency department, so how they are triaging in the ER and moving to the wards, isolation, and the critical care department. Same way, the pathway have been defined. My aim will be to enlist and to have a revision for all of the participants, that specifically in the maternity hospital, if the patient who is pregnant or having any obstetrical disease, they are coming and presenting to the ER, how we are moving to the wards and to the isolation and to the ICUs. We will discuss the evidence of being pregnant during the pandemic. We will start with the planning pregnancy during the pandemic. Most pregnant women in the mid-pandemic or not will be asked that how to create a birth plan. Is there a brief documentation which is outlining the preferences and everything? The thing is that those families who are expecting pregnancy during the pandemic, or those who have planned or accidental pregnancies there, they have a lot of questions. The pregnant female is already have a question being good health, maternal health, mental health, and concern about the baby. Now they have a lot of concerns about the COVID-19 as well. They needed to have a brief knowledge about the COVID-19. They wanted to have some specificity in questions, specific answers, which can be answered, especially during the time of pandemic. What are the protections we have to take while pregnant? It is around 5th to 6th month is there that we are passing through the pandemic. The data about COVID-19 pregnancy is limited, but still we have some data which we can share. Pregnancy itself is a state in which immune system of the mother is suppressed. So if we see the theoretically, a pregnant woman may be more susceptible. But up till now, the data which have been collected, we have seen that the pregnant ladies are not contracting the COVID-19 with severity of the signs and symptoms. We don't know yet that what might happen if COVID-19 is contracted in early pregnancy, because the last 4 or 5 months when we are dealing with the COVID-19, we are facing the females who are coming in the last trimester of pregnancy. So yet a knowledge about the first and second trimester is awaited. But one thing is reassuring about the pregnancy and the children, that the babies who have been born during this pandemic seems to be protected, seems to have a 0% vertical transmission, having a few cases of 2 cases in China, which is still concerned that they have contracted the COVID-19 from the mother or from the healthcare or after the birth by the family members. But still the data is going to be collected, and it's being studied in UK and Italy, yet not published. So we have good things that no vertical transmission up till now. Amniotic fluid, umbilical cord, blood with the throat and nasal swab of newborns have been tested, which mostly came negative. Pregnant women are at a heightened risk of acquiring COVID-19. So they should apply what kind of precautions to prevent from this COVID-19 contraction? Almost the same measures which have been taken in all of the patients, like social distancing, hand hygiene, sanitizer use, washing the hand with soap, these all, and prohibiting themselves to meet in the public is the main standard precautions for these pregnant ladies as well. If you're pregnant and then think you may be exposed, you may still be asked to stay home or monitor symptoms to assess the tests remain, which is unlimited. We'll start with the COVID-19. COVID-19, as it explains from the word, CO is for corona, VI for virus, and D for disease. And 19 means that it happened in the last month of December 2019 in Wuhan city of China. It is contracted by the coronavirus. Coronavirus, we know that there are enveloped kind of viruses, there are non-enveloped kind of viruses. COVID-19 is enveloped virus. It has a positive single-stranded RNA genome. Why it is called corona? Because it's taken from the Latin word, which means like a crown or halo. And if we see on this slide, on the right upper corner, red-colored protein spikes we can see. So when we view this COVID virus under the electron microscope, we found that the surface is covering in column-shaped protein spikes. If I go to the brief of coronavirus, it has a family which is called Coronaviridae. It has a subfamily which is called Orthocoronavirinae. We all know that the genus of coronavirus has 4 types: alpha, beta, gamma, and delta. Well, COVID-19 belongs to the group B, and B has 2 groups, 2A and 2B. It belongs to the group 2B. So genus of coronavirus family is 2B. Initially, it was named as interim name by WHO, that novel coronavirus, COVID-19. But actually, it has the same resemblance of the outbreak which occurred SARS coronavirus in 2003. This outbreak occurred in many countries, including the Saudi Arabia, and SARS-CoV has almost the same resemblance which have been given to COVID-19. So its interim name now is SARS-CoV-2. So it's an enveloped virus. It has a genetic material. It usually have a respiratory kind of illness. It has a specific mode of transmission, which is either contact transmission or can be airborne. We will talk about the airborne transmission in the next slide. And few studies have been seen that this virus can be contracted through fecal-oral route as well. So if we go with the pandemic which occurred in 2003 SARS-CoV. After that, we were having 2008 in South Korea, and 2012 there was Saudi Arabia. There was MERS coronavirus, which was having an epidemiology with camels. History of camel was there. So now in 2019 we have SARS-CoV-2, which originated from the China, Wuhan city of China. Initially, it was thought that it has a zoonotic transmission, especially from the bats, and then it's gradually involved the whole world. Up till now, if I talk about the cases of coronavirus, all of you know it around 10 million people have been affected by COVID-19. Though the recovery rate is good, but still the mortality has been happened all over the world as well. What are the signs and symptoms of COVID-19? If we see, it started with a major symptom, which is 80% of the people getting a fever. Fever is high grade, which usually goes to 100.4 Fahrenheit or higher. It's usually the fever which is not subsiding even with the tablets or cold sponging as well. Patient can have cough and usually starts as a dry cough and can have a shortness of breath, but usually starts with the respiratory illness. We will discuss the definition in the coming slides of this, that what kind of respiratory illness we have. Following, if it is involved fecal-oral route, can have vomiting, can have diarrhea, but it's low percentage. 4.5% cases have been seen with GIT symptoms as well. So transmission, if we go with the, so if in the signs and symptoms, most common three, remember, high fever, then goes with shortness of breath and the dry cough. Incubation period usually goes that when the person infects with the COVID-19 and exhibits the signs and symptoms of the disease, it's called incubation period. Usually it goes from 4 to 7 days. 5th day, we find that these patients can have the signs and symptoms, but some cases have been seen that at the day of 27, the cases appeared with COVID-19 with having an infective picture. Let's come to the mode of transmission. As I was talking, that mode of transmission is via respiratory droplets that the people exhale. And when the people exhale, it has a different transmission. It comes to the person who is in the distance of less than 1 meter. And it can come to the surfaces which are nearby to him in form of fomites, which the person usually touched, that areas can have infection. Now, if I talk about the respiratory infection, respiratory droplets, it's of two sizes. One is more than 5 to 10 micrometer, which is called respiratory droplet. And which is less in the size, it's called droplet nuclei. It's less than 5 micrometer. Current evidence shows that COVID-19 virus is primarily transmitted between the people through respiratory droplet and contact routes. Now, if we go with the droplet nuclei, which is less than 5 micrometer, it usually can have, with sneezing and coughing, can cover more than 1 meter distance and can infect the people through sneezing and coughing. The fomites in the immediate environment around the infected person can get infected, and the other person can get infected by direct contact and indirect contact. Like we, the healthcare workers, we are having a stethoscope, thermometers, and they get infected. And then if we touch it, it goes to have an infection. So airborne transmission, I have put the word here, query. The airborne actually is different from the droplet transmission. If we see from the word that it is the presence of microbes within the droplet nuclei, less than 5 micrometer in diameter, and it can remain in the air for long period of time, more than 1 meter. In this way, those persons who are dealing the patient directly, and especially those who are dealing the airway of the person, should take the precautions of airborne. So airborne precaution, especially once we go with the healthcare workers, we are taking the airborne precautions that the droplet nuclei can affect the healthcare worker. We're usually doing the surface disinfection with ethanol. Few studies have been found that patient has a contraction of COVID-19 through fecal-oral route. Up till now, 1 or 2 study has been found, but it shows that there is a transmission through fecal-oral route as well. Let's come on the main slide of my lecture, which is our interim guide to COVID-19 definition. So if you see on the right side of my slide, it's written clinical presentation and the left side is written epidemiological link. Now the clinical presentation is of two kinds. That one is the patient with acute respiratory illness, and if he has sudden onset of fever, which is mired or by history, dry cough or shortness of breath, and in the 14 days prior to symptom onset met at least one of the following epidemiological criteria. What is the epidemiological criteria? So he has fever, cough or shortness of breath. And if he linked with epidemiological link, like he had visited or being a resident of high risk area for COVID-19 in the kingdom, like Riyadh, Makkah, Medina, Jeddah, Hafuf, Qatif. Now we can say almost all the kingdom areas or world mostly cities are having a high risk area for COVID-19. Or if the person is in close physical contact with the positive COVID patient, or if he is working in healthcare facility and having a positive COVID patients. So this is the definition number one, that patient is having acute respiratory illness, fever, either cough or shortness of breath, and in the 14 days prior to symptom onset, if any having epidemiological link, fulfills the criteria to having a suspicion of COVID-19. Those patients who are admitted in ICUs or in the ward with unexplained community-acquired pneumonia or healthcare pneumonia, they don't need epidemiological link, but they need to be suspected COVID-19 to be excluded. Let's, from this slide, we come on the next slide, which is CDC Vakaya from Saudi Arab guidelines, that they have now new updated things, that the clinical presentation of acute respiratory illness, which I talked, fever, cough or shortness of breath, no need to have an epidemiological link. It needs to have been excluded. That patient should be gone for COVID-19 suspicion. Yes, if patient has headache, sore throat, rhinorrhea, and GI symptom like nausea, vomiting, or diarrhea, then we go with the epidemiological link, that if these symptoms are coming with the contact with confirmed COVID-19 case, or lived in or worked in a facility known to be experiencing an outbreak of COVID-19. So in the 14 days prior to these symptoms, if he has contacted with the confirmed COVID-19 or lived or worked in a facility, needs to be suspected with COVID-19. The three is almost the same, doesn't need epidemiological link, but patient is having an unexplained community-acquired pneumonia or hospital-acquired pneumonia, needs to be excluded and having a suspicion of COVID-19. What is the definition of confirmed COVID-19 case? This defined as the person who have been suspected, the case definition, and we did the nasopharyngeal swab with the PCR confirmation that COVID-19 is present. This is a confirmed COVID-19 case definition. Close contact like we are healthcare associated exposures having. We are dealing with the people who are patients who are COVID positive, or later on they become positive COVID. The persons working together in close proximity or sharing the same classroom environment with COVID-19 patient, traveling together with COVID-19 patient in any kind of transportation, living in the same household as a COVID-19 patient, defines as a close contact of COVID-19. Clinicians, we the clinicians, must think the patients who are coming with atypical presentation. Specifically, we have found the patients who are immunocompromised patients, like congestive heart failure, like we can say in the pregnant ladies, those who have the medical conditions, heart failure, liver cirrhosis, renal failure. If they're coming atypical presentation, clinicians should think about COVID-19 suspicion. I will go quickly. Dr. Saima is asking me that you have less time. So respiratory triage checklist. These are present in emergency room of every hospital. So as we discussed the definition of COVID-19, the respiratory symptoms, if any one symptom is present, it scores for adults 2. If he has cough, it will score 2. And fever, score 2. Shortness of breath, score 2. And any epidemiological link, which we said that in the 14 days, we found it out, it leads to have a score of 3. So 3 That means any one epidemiological link with any one symptom, if score is more than 4, it will lead to have a suspicion of COVID-19. Let's see those participants who are attending the course from maternity hospital of King Saud Medical City. Patient is coming and we did the visual triage. Nurse will score the patient. If the score is less than 4, she will send this pregnant lady to the regular triage area. But if the score is 4, she will ask 4 things to do now. Offer the face mask to the patient, isolate the patient, and she will ask OB/GYN physicians to evaluate the patient within 10 minutes. In case isolation is not available, the patient will wait in respiratory waiting area. Now, once the OB/GYN physician evaluated, and if there is any medical condition and needed to be evaluated by the medical specialist or consultant as well, and if the score is more than 5, then the swabbing will be done by the staff nurse responsible in that area, but this swabbing will be done in negative pressure isolation room, or that room must have HEPA filter. Now, after this swabbing, it will be decided this patient is for admission or for discharge. If the patient is going for discharge, home isolation, that means the physician have thought the patient is stable enough to be discharged for home isolation till the result of COVID-19 is available. On which basis the patient is going to be stabilized, like maintaining saturation more than 92% on room air. If respiratory rate is less than 20 per minute, and the patient has clear radiological, no radiological changes on X-ray, which can be done by shielding the baby, then we can consider the patient for home isolation, which will be followed by the local infection control measures like 14 days, when to get the swab, and if positive, then what's the next. If COVID-19 sample has been taken, decision for admission has been taken, then now evaluation will be done. If the patient is critical, immediate call will go to the maternity ICU physicians. And if the patient need admission inside the ICU, this patient from the same area will go to the central hospital ICU. Recently, the guidelines are very clear from the maternity hospital higher authorities and from the critical care department and medical director of King Saud Medical City. Now, the process has been changed. From that area, patient will be moved by ambulance to the central hospital ICU. If the patient is not critical, but from the OB/GYN point of view, the patient is in labor, then admit in isolation room in labor room, or if not in labor, patient will go to the gynae A or gynae B in negative pressure isolation room or HEPA filter availability. Now the swab result came. Next 48 hours or within 1 day or 3 days, swab result come. And if it is positive and it looks that patient will stay more days, there is an agreement that the patient will be transferred. Initially, it was decided to go to the Imam Abdurrahman Faisal Hospital. Now even King Saud Medical City can be transferred to the ICU or to the isolation wards. Patient will be, I forget to write down swab result positive or negative. So just assume that swab result arrow, which is going to IAFH, Imam Abdurrahman Faisal Hospital, this result is positive. And the downward, if swab result is negative, then we need to reassess this patient if this patient needs hospitalization or not. If not, discharge home. If yes, OB/GYN doctor and physician will evaluate the patient. If patient has no symptoms and can be out of isolation, then shift the patient to single room or 2 patients per room for 14 days under observation. After 14 days, patient can be shifted to the ward. I will go quickly. Now, you have decided with this slide that if the patient in maternity hospital is positive COVID, you need to transfer either to King Saud Medical City inside the ICU, or you want to transfer to Imam Abdurrahman Faisal Hospital. Because initially Imam Abdurrahman was a COVID center in the phase 4, and then gradually it was supposed to come to the King Saud Medical City. There is a clear crisis management course is there. Once the patient is positive and unstable, needing ICU, the crisis management will be informed. There is specific hotline. The consultant ICU will arrange the bed inside the King Saud Medical City. In form of Imam Abdurrahman Faisal Hospital, a medical report will be written and a HALA number will be created. Once this coordination has been taken, then a specific ambulance will be in movement, which will take care of COVID-19 patient. The staff nurse of the crisis management team will take care of the staff nurses, physicians, and all the team members that they have been provided with specific PPEs. And at the same time, they are moving with full precautions of COVID-19. And in this way, the pathway of transferring COVID-19 will be taken place. My lecture is almost finished. Actually, I'm doing courses with Dr. Madi. So usually is my first, when it goes with my first lecture, the people are not usually aware of the Zoom technology. So when asked the questions, they don't ask the question from me. And I usually goes that either the people understand my question very well, but I feel the people are not aware of the Zoom technology in the chat list. So Dr. Madi, actually, I did some questions and I will do the answers. Actually, there are some healthcare workers who are pregnant. They asked me actually during the course that, I mean, if we are concerned because we are pregnant now and we are working in ICU. So Dr. Shehzad, some questions in our mind. So I tried to have some questions. So I will go quickly, Dr. Madi. Question number one, what effect does coronavirus have?
Let me ask you, Taib. You will
Yes,
ask
Dr.
yourself. No, continue. Continue, boss.
Thank you very much. Thank you.
Very sure, I'm joking.
So answers, the people can read it out, but I will go quickly. What effect does coronavirus have on pregnant women? Generally, pregnant women don't appear to be more like to be severely unwell as compared to the other healthy adults. And those patients who have comorbid diseases like diabetes, hypertension, ischemic heart disease, immunocompromised, specific diabetes, age more than 50 years, bronchial asthma, they have been more contracted with the coronavirus. Up till now, the effect of females and with the pregnant females, the numbers are very less. Usually, they appear to be more common in older people and those with weak immune system. But if you develop severe symptoms or your recovery is delayed, this may be a sign that you are developing more significant chest infection. That requires enhanced care. Then you better contact the medical health center or hospital. Question number two, what effect will coronavirus have on my baby if I am diagnosed with the infection? We are just beginning to learn about the new virus, but up till now, there is no evidence to suggest and any increased risk of miscarriage due to this COVID-19 infection, and no evidence of vertical transmission yet. There are 2 cases in China that babies were examined through the throat swab or through the umbilical cord or amniotic fluid that usually it remains negative, but found 2 patients, babies positive through nasopharyngeal swab. So still we are waiting for a good publishing data. Dr. Hazmi is also with us in this course today, so I think he will have a more detailed answer about this. Question number 3, what can I do to reduce my risk of catching coronavirus? No difference between the adult patients, male or female, or the pregnant females. Almost same remains, that you take the standard precautions of regular hand washing, cough etiquettes, and social distancing, and avoid the use of...
Yes. Amori, you will cover all the calls topic with these MCQs.
So I will take 4 minutes and I will go quick.
Okay.
I think I will not quickly. Why are pregnant women in a vulnerable group? Usually the pregnant females were found that they were contracting the viral infections more worse in pregnant women. Till now, evidence is lacking. Coronavirus is not infecting the pregnant females very badly. What do I need to do now? Follow the government advice about social distancing and standard precautions. More careful about these precautions, especially when 3rd trimester of pregnancy. If you are a worker and facing the public facing role, same effect usually should be evolved. Face mask, minimal social exposure and try to take vacations or change your capacity of work when your third week of trimester. Any advice if I'm a healthcare worker and pregnant? Usually less than 28 weeks gestation. If you are a healthcare worker, mostly if you don't have an underlying medical condition, go normally with the same precautions as we are doing. But if you are in ICUs, operation theater, or wards, then better to use PPEs. But you have to be very careful in the third trimester after 28 weeks. If underlying medical condition, we will suggest not to take the areas which are COVID involved. So you should be away from this COVID areas, take maximum vacation, and discuss your individual circumstances with your local occupational health managers. What should I do if I think I may have coronavirus or been exposed? Same respiratory triage checklist you have to see. And if any signs and symptoms are there, you have to go to the physicians. How will be tested for coronavirus? Pregnant females or the normal males? There is no difference between both of you. Nasopharyngeal swab is the sample which have been taken from the pregnant ladies or the normal people. Could I pass coronavirus to my baby? Yet published data awaited. Up till now, no vertical transmission. Will my baby be tested for COVID-19? If you are suspected or confirmed case, yes, newborn baby will be tested. Will I be able to stay with my baby, giving skin to skin if I have suspected or confirmed coronavirus? You have to take full precautions to touch the baby. Otherwise, 14 days isolation has been advised in China. The last question, Dr. Mahdi, will I be able to breastfeed my baby if I have suspected or confirmed coronavirus? Yes, up till now, no evidence showing that virus can be carried in breast milk. The well-recognized benefits of breastfeeding outweigh any potential risk of transmission of coronavirus through breast milk. The main risk of breastfeeding is close contact. So at that time, it has been advised that you take the mask precautions. You wash your hands with hand washing like sanitizers or soap, and then you breastfeed your baby. But if you choose to breastfeed your baby, these precautions can be recommended, which we are discussing as a standard precautions, or you can think to have this breast milk pumps. Breastfeeding pumps can be used, milk can be extracted, and baby can be fed with this milk. Last slide, that our return of healthcare workers infected with COVID-19, this is leads to the doctors and nurses of maternity hospital as well. It has been updated in 2nd May 2020 in the CDC and Vakaya guidelines of Saudi Arabia, that if healthcare worker is asymptomatic, but it came positive, he will be retested at 3rd day of confirmation. If he get 2 negative samples, 2 consecutive negative samples, then there is no need to repeat and patient can join the work. The thing is that if you are with symptoms, so you will wait till you get resolution of symptoms. Once resolution of his symptoms done, you will do samples. It can be continued every 2 days till it becomes negative once and can join the work. If healthy or asymptomatic, then 1 negative sample taken at 5 days or more is enough to return to work. Remember, once you are joining the work, you do the source control, wear the face mask and monitor your symptoms. If your symptoms are more, then inform your supervisor on duty. Thank you very much, and I'm sorry to Dr. Saima and Dr. Mahdi. Actually, the next lecture is for Dr. Mahdi. But still, if you have any question, I am here to answer.
Almost you answered all questions, all the course.
Thank you very much, Dr. Mahdi.
I think there will be no questions. But still, if any questions, you can leave in the chat room and we can address it later. And I believe we should progress towards the second lecture, which will be about overview of COVID-19 diagnosis and management protocol. As I already told, it will be delivered by Dr. Ahmed Mahdi. He is the head of Physician Education and Training Division. And I think how much I will express for him, it will be less. He's a known personality, not only in the KSMC, but even outside Riyadh also, and at national level, mashallah. And I think the best person to talk on this topic, um, I think Dr. Mahdi, I will leave the space for you.
Thank you so much, Dr. Saima. Thank you, Dr. Shahzad, for your very good presentation, really. And I can disclose, Dr. Shahzad, he touched all lecture except his wife lecture, which is Dr. Saima. Yani, I think Dr. Hazani, he cut a piece of his lecture, and Dr. Tasmiya, but he is worried to touch the CBR of Dr. Saima, which is his wife. Thank you so much, actually, for your presence with us. This is the best couple we have in our ICU, really, actually. Assalamu alaikum. I will go through the quick management of the critically ill patient with COVID-19. I don't have something specific for pregnant lady in this curriculum or protocol, we can say, but I will keep for my next speakers to talk about the specific considerations regarding the management of the COVID-19 patient with pregnancy. So I will go very fast through the local and almost looks like the same like international guidelines of the patient critically ill. Dr. Shahzad stated clearly this virus is a respiratory virus. Mainly is a severe acute respiratory function caused by the acute respiratory syndrome, which is whatever the pathophysiology behind, we have a patient with ARDS. And you can excuse us. I know we have a diversity of the OB-GYN, nurses, ICU physicians. So I hope we can touch all the specialties we have in the course. So the coronavirus definitions, the most common presentation of the coronavirus is respiratory manifestations. We have another atypical presentation, but the most common one. I'm always saying management of the corona patient is different from any different viral pneumonia. We have passed many outbreaks, starting from H1N1 to MERS-CoV and ended with the coronavirus. SARS, fortunately, we don't have it here. It was originally from the China during that time and Far East. But what is the unique of this or the specific characteristics of this virus? It's transmission and it's spreading very fast and very. We are always saying you have two big domains. First one is the clinical management of the virus, of the symptoms and signs of the presentation of the virus, and the same importance, maybe for my mind, it is more important and more priority than which is the safety of the healthcare workers and the staff working in this field, because it is very rapidly transmissible. So both of them are the two main domains. Even usually we can have some clinical management lines which can be affected by the safety. For example, we can bypass, we can skip some of the clinical management due to the safety. Not go with the bronchoscope, for example, for the patient. I will not go with rapid intubation. Even the CPR, Dr. Saima will mention, I can hold, I can wait, I can postpone the CPR management because of the safety until I will have full PPE. So safety and clinical management both are the same important for management of the case. As we have mentioned earlier, the most common presentation of the COVID patients is respiratory syndrome. This is the most common cause for admission to the ICU. Usually it's coming in the second or third patient. We have patients, we can say those will be at risk. Those will be at risk of severity of the disease. This is one depending on many factors. We have three main big categories. We can define this patient will be deteriorated and it will be severe ARDS. The first one, it's demographic data of the patient, whatever what he has, his age group mainly. The second one, his comorbidities, usually coming with cardiovascular disease, diabetes, bronchial asthma, or pregnancy, of course, one of the most important of them. And we have our own specific epidemiological and comorbidity in Saudi Arabia. Worldwide, the cardiovascular with the first, but we have here the diabetes mellitus in the first comorbidity. Another factors which is very important, which how the patient was presented as regarding lab investigation. We have some lab investigation telling us you can diagnose the patient by lab investigation. Of course, not sensitive like PCR, but we can highlight it. The most common of them is lymphopenia. They are coming usually with lymphocytic count less than 0.8. They can come with elevated troponin. They can come, mostly of them coming with elevated D dimer as well as ferritin. Ferritin and D dimer, one of the most prognostic factors. You can say your patient will worsen. You can follow up with them twice weekly, and you can know your patient will deteriorate, will need aggressive therapy or not. So the most important lab findings for the severe cases is lymphocytic count, troponin, LDH, C-reactive protein, D dimer, as well as ferritin. Usually, as we have mentioned early from the studies, cardiovascular is the most common. This is worldwide. This is in China and USA. But in Saudi Arabia, the most common comorbidity is diabetes. Right. Pregnancy, we have some of the pregnant lady, of course, but the diabetes is the most common of them. And unfortunately, even the virus, the patient with diabetes in COVID virus, you know, there is ACE2 receptor present in the pancreas also. We have difficult to control. We have many patients of COVID coming with DK, very difficult to control their RPS, either severe hypoglycemia or severe hyperglycemia. Very difficult to control their RPS. As well as they can come with chronic bronchial asthma or comorbidity. So this is the most common presentation. You can see this figure showing the age distribution of the COVID patient in critical age. This blue color column, it is denoting how is the age of distribution.
Dr. Mahdi?
Yes, boss.
Can you share the presentation, please?
It's not clear?
Share your presentation, please. It's not sharing.
I stop share. I will go back again. It is okay now?
Yeah, now it's sharing. Thank you.
Shared? Okay. So I will go to the, stay again with me, Ahmed, if I am not. Slideshow. Still shared?
Just can you make it full screen, please? Yeah, it's sharing now.
Sharing now. Okay. So if you look to this figure, you will know how is the age distribution of the COVID patient. This is worldwide. This from United States, over many patients of them, 4,000 patients. You can see we have two peaks here. If you look to this blue color, two column, you have two peaks of age distribution. First one is 2024, last one is 65 to 84. But we have noticed here, we have over 300 patients in our city. We did notice most of the age group coming between 40 and 50 years of old. So this is worldwide age distributions. But if you did look to this blue, orange line here, this is the mortality rate, or let us say, be clear, this is the fatality rate. Fatality rate means how many patients will die over how many patients infected with coronavirus. The younger group, they doesn't have high fertility rate, but the elder group, for that, usually they are saying the most elder people have to stay at home because they have high mortality rate. It can be reaching to 20%. And this is the cause of the highest mortality worldwide in Italy and in Spain and in France and USA. Because the elder people, they are joining the work, they are in the community. So whenever infected, 20% of them almost will die. So age distribution is very important. This is scheme showing how the viral acts. Simply, we have different phases. First, the virus will invade the respiratory system. If you look to this blue triangle here, this is the viral response phase. This viral response phase, it can be during incubation period of the virus. The patient can have no symptoms. He can come with very mild symptoms even in this stage. With more viral replication, he starts to have symptoms. After that, this orange triangle showing the host response. How will the patient respond to the virus? Based on his immunity. If the patient has good immunity, always he can bypass this stage. He can just go only to the mild stage. But if the immunity is low, or if the virus is very strong, so he can fail to fight this virus. So we can have at the end the hyperinflammatory phase, and many patients coming to this cytokine storms and the multi-organ failure and the ARDS. So started early with the mild symptoms, ending with the multi-organ failure based on the viral response. Let's take this in details. So if you categorize your patient, incubation period, when the virus starts to invade the patient, he doesn't have symptoms, then he can come with some of symptoms like fever, like pony ache. Then pneumonia can come in the third stage. Pneumonia can be without hypoxemia, which is early pneumonia, can be with hypoxemia, which is late third stage. Kind of store, either severe ARDS, multi-organ failure. As you can see it here, as we have mentioned, fortunately, most of the patient coming, 80% coming with mild. Severe, which is requiring oxygen therapy, reaching to 14%. 5% of them requiring invasive intervention or invasive mechanical ventilation, which is the more critical patient. Then the other symptoms, as we have mentioned early, prodromal symptoms, most, alhamdulillah, of our healthcare worker got infected in this stage of prodromal stage, coming with sore throat, loss of smell, loss of taste, high-grade fever, pony ache, whatever the presentation. Fever can continue for 5 to 7 days. If the patient start to have some sort of patchy infiltration of drug, usually coming in the peripheral of the X-rays, he will have a pneumonia. If this pneumonia coming with hypoxemia, it will be severe, then it will end with multi-organ failure if the patient deteriorated. I will go very rapidly through the organ failure. Usually coming with hypoxemic respiratory failure, 90% of them, shock stage either due to cytokine storm late or due to affection or due to microthrombi, which is one of the main pathophysiology of the COVID-19 patient can come in with acute coronary syndrome or cardiogenic shock, acute kidney injury coming to 20% of the patient. If you take sample for this patient, you will find mild acidosis, mainly respiratory, raised CK, as we have mentioned early, lymphopenia, D-dimer will be high, LDH will be high, ferritin will be high, can come with some sort of lymphocytic, leukocytic count can be high later on. LFT can be increasing either due to the effect of the virus on the virus, the liver, or the effect of the drugs you are giving to the patient. Difficult to control their RPS. As we have mentioned early, lymphopenia, one from the cardinal symptoms. And if you look to these graphs, many patients, this is the blue color line, this is the patient who survived. This is the yellow color, the patient who didn't survive. As you can see, more patients with lymphopenia, they have likely to die. So we have lymphocytic count 0.8, 0.5, 0.4, and down more patients likely will die based on the literature. If you go to the D-dimer, which is very important predictor for hospital mortality, yes, whenever higher D-dimer, more patient likely will die again with the D-dimer. And you have noticed this is frequently. You can find the D-dimer reaching to 60, 70. For that, we categorized in the management, Dr. Bashir will talk about on the anticoagulation therapy based on the D-dimer. If you look to this graph, sorry, in China people, you can find the red color line, as we have mentioned, patient non-survivor, died dead patient. As you can see it here, D-dimer going higher from 0.3 to 2.6 to 14 to 23 up to 42 and even higher. So more likely patient will die. The blue color, which is the less D-dimer, good predictor. By statistical analysis, you can find it here, very significant. Very significant. If you look to D-dimer, you can know your patient mostly will die or not will be survived. Of course, with the management, you can change this scheme. If you look to that, Dr. Shazati talked about the nasopharyngeal swab and laryngeal swab and the investigations. Of course, PCR, one from the sensitive, I'm not saying 100% sensitive, but sensitive test you can do early in the patients. Let us take example to know how sensitivity of the PCR. For example, if you have a patient in ER, he came, and the doctor is intubating this patient of COVID positive. So we have epidemiology, this doctor exposed to a patient with positive COVID, right? And he shows signs and symptoms after 7 days. He did at beginning PCR from pharyngeal swab from the doctor, he found it negative. After 7 days, he developed fever and shortness of breath, and this X-ray, typical X-ray of the COVID patients. And he did another PCR from nasal swab after 7 days, the doctor, he found it negative. So I have the choices here. So we have 2 swab negatives. He has exposure to the positive case. He's intubating, one from the most risky procedure during COVID patient, which is intubation, right? And he has 2 negative PCR 7 days in between. Radiologically is COVID positive. So all options, I will not go through in detail, but doctor as a COVID positive patient and you will repeat for him again third sample, or you will confirm with the 2 negative sample that he's not COVID and you treat him as normal community acquired pneumonia. Based on the radiological lab, clinical is COVID. Based on the 2 PCR, he's negative. But still, with this, I will go to the answer rapidly. Yes, I will repeat again PCR from the intubation if the patient is intubated. I can go with the bronchoscope, which is more sensitive, but as we have mentioned early, I can avoid some procedures because of its risk, right? Even sensitivity is higher with bronchoscope, but I will not do because of the risk. As you can see it here, if I take sample from bronchoscope, sensitivity of PCR will be 93%, rather than nasal swab, which is 63%. But still, I will not do the bronchoscope because I'm worried about the the infection that's spreading with the patient. So I want to say the message here, the bottom line, we have 2/3 of the patient, yes, positive, but still we have 1/3 which can come false negative. Don't rely on if you have a patient with clinical, radiological, and lab confirmation that he's positive. Management, simply, if you have the patient asymptomatic, just monitoring, isolation, and trace his contacts. If you have the patient with mild symptoms, good hydration, antipyretics, and hydroxychloroquine, plus or minus, I will keep it for Dr. Bashir to go in details about this. Antiviral, of course, I will not talk in details, but still also query for mild to moderate cases, and you have to have in 7 days from presentations. Another line of management, immunomodulation, which is we have 2 lines of them, like corticosteroids, like tocilizumab. You can go when you have suspicious of cytokine storm or multi-organ failure in the latest stage. Of course, oxygen supply, it is the mandatory from the mild until severe cases with whatever I will come through it in our protocol. I will show the scheme of the management, how we can do it. This is simply, if you look to this green line, this is the viral invasion of the patient. Starting with viremia, you can see the purple color here. This is the inflammatory response is still low. When it starts to so the patient can have high peak of viremia, but still saturation is accepted. It will fall down when the response will be failed. His response will be failed. At beginning, I need early intervention with something like awake proning, like oxygen therapy, like high flow nasal cannula, and late stage, I can need intubation. All of us at beginning, we were intubating our patient early because of tachypnea, but later on, we did found poor outcome with them. So as much as we can, we are trying to go invasive. The management, nothing approved. Whatever the literature, Dr. Bashir will talk about in details, but we are going with supportive care. Oxygen therapy, good hydrations, antibiotic management of the complication. Many guidelines worldwide. Canadian Survival Services Campaign, Australian, American guidelines, even we have our Saudi guidelines here for the management of the COVID patient with consideration with special consideration. I will post for you all the guidelines we have, but I want to know that we have our own protocol, which is really very informative and coincide. For example, if you want to go through the ventilation protocol, this is the ventilation protocol for the patient with COVID-19 on the left side. I will post it in the group to see it in details. I will not go in details. If you will go to the intubation criteria or awake intubation, you can find our protocol. We make it simple. Even the physician order, I will post all of this in group. This is the physician order. I will show in detail this one. And even some of the fatwa, which come touching the patient with COVID, how we will deal with the healthcare workers. We are trying to minimize the paperwork. And my advice for you in ICU, as much as you can minimize during the crisis, all paperwork. So what we are doing this in our ICU now. I just want you to go through this protocol. We have our team protocol, and all of our consultants, Dr. Shazad, Dr. Simon, Dr. Khair, they are a part of this protocol. I collected in this diagram. I can show it you in the PDF to can review it in details. I hope I can share it. Yes. No, this one. Sure. Here's my PDF. This one, yes, I hope so. It's clear here, you can see it. This is the collection of the protocol in one paper. You can find it. I will explain you in brief, but I want to be sure that you can show it in the screen or not.
No, Dr. Mahdi. Open it. Needs to open.
I will stop again and I will share it again. PDF. Ahmad, you had it? خلاص. You did it, Ahmad, صح? Ahmad, share it with you.
Yes, it's shared now.
Okay, so this is the collection of our protocols in one page. You can look at, if you look to up, you can move it up, Ahmad, please. Give me the top of the page. You can move it. Now I share mine. It is clear or not?
Yes, it's clear, Dr. Mahdi.
Yes. Okay, good. So now you can see it. This is the timeline. This is the top timelines in the first week, second week, third week. And if you look from the left to the right side, if you go to the signs and symptoms here, this is the green table here, you can find it. First is symptomatic, then you have some sort of dry cough and fever, then shortness of breath and tachypnea and hypoxemia. Last one, organ failure. This is the time. If you look to the lab investigation, you can find here in the yellow color, the line after lung ultrasound, one from the very important and easy and non-invasive technique and minimizing the exposures, which is lung ultrasound. You can define your patient with localized P lines, diffuse P lines, and after that you can find subdural consolidation and subpleural and alveolar consolidation by the ultrasound lung. CT scan usually, yes, it is diagnostic, but usually we are not moving the patient a lot between departments to avoid contamination for other places. So the most characteristic signs for the ground glass appearance because of interstitial edema of the alveoli. So we have it at the beginning here. Later on, the patient can have some sort of consolidation or the white lung. When you find the COVID patient with cavitation or with effusion is not COVID. Again, CT scan, don't do it if you if you have proper diagnosis, definite diagnosis, don't expose your staff or the radiology department or moving your patient in corridor to take him to the CT. It is not routine, right? Okay. Then, if you go to the respiratory support, this is the asymptomatic patient, this is the mild, moderate, severe, and critical patient. We started usually with the nasal cannula 4 to 6 liter. If you can see it here, I can maximize more. Yes. Nasal cannula 4 to 6 liter per minute, non-rebreather mask 10 to 15 liter per minute, awake proning, one from the most good outcome. Keep your patient to treat his silent hypoxemia as well as his increased work of breathing. Let him proning for 3 hours, and we have protocol for awake proning. I will share with you in the group. So this is the respiratory or oxygen therapy management. If this failed, you can go with more option, FI2, like high flow nasal cannula. Again, awake proning with high flow nasal cannula, very good outcome. Many patients avoided intubation because of high flow nasal cannula. CPAP, which we are preferring nowadays, the helmet. Like a CPAP, but a helmet cover with neck cushion, preventing leak with pressure support. You can use this helmet. Very good outcome in Italy, and we start to use it actually here. So this is the oxygen therapy from mild to moderate to severe. So nasal cannula, non-rebreather mask, high flow nasal cannula, and CPAP and the helmet. Keep your eyes on your patients. They always tachypnic, they always dystatic. They can improve. You can accept even saturation for them 88 or 90 if they are doing well, but don't accept if they increase the work of breathing. And based on our experience, we are not going aggressively now in early invasive mechanical ventilation because we are worried about the worst outcome or the bad outcome. Proning after mechanical ventilation for 16 hours per day. It can be extended to 6 to 8 days. We can do that. ECMO, in very selected cases, we are using actually because of the crisis management and the consumption of resources. So we are limited the ECMO in such cases. So this is the respiratory management in this protocol. If you go to the pharmacotherapy here, pharmacotherapy needs special consideration. You have to go to each drug in details. You have to review the contraindication, indication, side effect, as well as drug interaction. Of course, Dr. Bashir will cover in details, but simply, if you look to this graph, paracetamol can start from early until end. Antiviral therapy, whatever you have, triple therapy, lopinavir, ribavirin, interferon, favipiravir, or remdesivir, Dr. Bashir will talk about it from mild until the end. Consider, I'm not accepting now hydroxychloroquine, but it's still in mild case, still in the protocol of MOH. Azithromycin and the antimicrobial based on the presence of the pneumonia or not, from mild until severe. If you look to low molecular weight unfractionated heparin, from the very important line of treatment, Dr. Bashir again will talk in details about it. You can start early, even with high dose, even therapeutic in some cases. Steroids. All of us know steroids actually, either dexamethasone, which is coming to the floor nowadays since 2 weeks back, until methylprednisolone, anti-leukin 6 tocilizumab, convalescent plasma and the plasma exchange. And we have here down the guide for each drug of those. So simply, this is our protocol, and in one page you can go through it. It can summarize everything for you as regarding the signs, symptoms, the radiological investigations, respiratory support, as well as the pharmacotherapy. Again, if you like to get, I can share with you also. We make our life easy. Even physician order, we are doing it printed out and easy, as you can see it here. If you can see, simply no need to write in the physician order, minimizing the paperwork. This is printed, ready-made, physician order set for the management of the COVID. Just you will check only for the lab you need to do daily, for the daily laboratory investigations, for the sedation you want to process, for the muscle relaxant you want to go through, cardiovascular system, what is the vasopressors you want to keep the patient on, the respiratory, what oxygen therapy you want to go to your patient. If you're going to mechanical ventilations, what mood you would like, just to check. It will take just 1 minute from the physician to write it. And antimicrobial therapy here, you can just check for the dose. Viral, antiviral.
Dr. Madi, again, we need a screen share.
Anyhow, this is the physician order set. I will share in the group. You can use it in your ICU. It will make your life easy, and instead of including everything, dexamethasone, tocilizumab, everything, just will sign at the end. Right? So we will share all of this protocol with you. You can use it in your ICU. It will be easy for you, and this is even the protocol. So this is the quick guideline for the critical area of COVID-19 patient, right? So by this, I can end my talk, and I will keep the special considerations of pregnant lady with COVID patients for my upcoming speakers, Dr. Hazdani, Dr. Bashir, Dr. Saima, Dr. Tasmiya. And if you have any questions about the clinical management, oxygen support, respiratory support for pregnant lady, of course, they have a special consideration for the pregnant lady, because actually, as you know, this FRC is low, so they are liable for hypoxemia more than the other patients. So they need more oxygen therapy rather than the normal patient, because they have limited reserve of oxygen due to their pregnancy. And one from the most common intervention, we can debating even the termination or the delivery of the fetus due to keep the cardiac output for the vital organ. This also, of course, need Dr. Hazani and OB-GYN consultant with ICU consultant to decide if this late pregnancy, like in the third trimester. So if you'd like to have any question for the clinical management of COVID patients, this is the outlines, or okay. I did finished. Screen not seen. I finished my talk actually. So if you have, we will share the slides in the group. Sure. Dr. Asama, she's announced for that.
Yeah. Thank you, Dr. Ahmed Madi, for such a great talk.
Yes, Ahmed, he shared the physician order form here if you would like to take a look at. We have it in all ICU, the cluster one. You can use it in your ICU wherever you are. للإحساء, or you can use it. Thank you so much. For any questions, I'm welcome.
I think if they have any questions, they can leave for us in the chat room.
Yes,
Yeah.
please.
And almost we are near to full. So if any of our new colleagues, they are joining us, I think we should make the room for the faculty. And we are already sharing the link for the YouTube. Some of our colleagues, they can join through the YouTube link also.
If you can, I will give. I will leave. I will go for round, so I can keep one seat extra for you, Dr. Saima.
Okay, thank you, Dr.
So excuse me, and best of luck for all of you, and really thank you for your effort, Dr. Saima, and for all the faculty, all the speakers, Dr. Hazani, we are Dr. Al Hazmi, welcome with you in our, and all the participants, really very welcome. And I just want to announce, I don't think so, Dr. Saima, maybe she forget, we have to have MCQ by the end of the course, but because of we have different specialties, we have different categories, nurses, ICUs, so we kept the certificate for attendance percentage. So we are monitoring your attendance by Zoom in every lecture. So 75% attending of the all time of the course, the certificate will be released for you for the course. The CME hours I did process, I'm waiting. Once you will have it, it will post, it will be 2 hours maximum, because the Saudi Commission, they said for online, only 2 hours. So if accepted, if approved, even later on, we will post in your account later on, inshallah. Thank you so much, and best of luck.
Thank you, Dr. Mahdi. So I would like to extend my thanks for Dr. Aisha. She's the medical director for Maternity Hospital. And it is really great appreciation for her, because her welcoming response and all her contribution to help us arrange this online course for our physicians and healthcare workers. And it was really a welcoming response from her, and I really appreciate. Now, as we are moving towards our next speaker, Dr. Al-Hussein Al-Hazmi. He's a consultant fetal-maternal medicine, and I have heard a lot about him and the contribution he is doing to our OB/GYN department is marvelous. And really, I appreciate your contribution in making this course valuable for all our physicians and healthcare workers.
It's my pleasure.
Dr. Yes.
Assalamu alaikum. Good evening, everybody. Thank you for Dr. Saima, and my voice is clear?
Yes.
Thank you, Dr. Saima, and other coordinators for this opportunity. I have a quick review regarding COVID-19 in pregnancy. I will cover prevention, clinical manifestation, course in pregnancy, prenatal care, management of labor and delivery, and postpartum care. For prevention, the social distancing, hand hygiene, disinfecting surface, wearing mask, and is a preventable measure like other non-pregnant person. So almost the same. That's fine. For clinical manifestation, a systemic review including 538 cases in pregnant women. The most frequent symptoms were fever, cough, dyspnea, myalgia, fatigue, headache. The other reported less frequently, like sore throat, rhinorrhea, nasal congestion, anorexia, nausea, and vomiting, and possibly abnormalities in the smell and or taste. The classification of the disease, just, oh my God. As you know, either asymptomatic or pre-symptomatic infection, mild, moderate, severe, or critical illnesses. So course, in pregnancies, as we know, most of the of pregnant lady are younger than middle age. So the majority of cases are mild. There is risk of developing severe disease, especially if there is a comorbidities like obesity or diabetes. Actually, the pneumonia, the incidence of pneumonia and ICU admissions is almost the same for pregnant ladies and non-pregnant. Actually, I have a problem here. Yeah. In systemic review, including 538 pregnancy, 15% of patients had severe disease, 1.4% has critical disease. Maternal ICU admission occurred in 3% of the cases. So, course in pregnancy. In same systemic review, they found preterm birth and cesarean delivery rate are increased. 20% delivered before 37 weeks, and 85% were delivered by cesarean section. Actually, there is another studies in American journals showed there is no difference, no increased risk of preterm birth and cesarean delivery with patients with COVID-19. There is different studies, different results. The frequency of spontaneous abortion doesn't appear to be increased. Neonatal complication with patients has COVID-19 most likely related to preterm birth and for the complication of the prematurity and adverse uterine involvement resulting from critical maternal disease, not because vertical transmission, because as you mentioned before, the rate of near zero, the rate of vertical transmission near zero. The possibility of vertical transmission has been reported, but still uncommon. They found the virus in the maternal surface of the placenta. Neonate outcome have been uniformly good for at-risk neonate in the absence of the other issue, such as prematurity and abruption placenta and all other pregnancy complication. For prenatal care, first of all, prevention exposure in the community, social distancing and hygiene measures are recommended. Patients with potential exposure and should have self-isolation and be monitored of the symptoms, the incubation period up to 14 days. For routine prenatal care in an affected woman, the American College of Obstetrician and Gynecologists, the Society of Maternal Fetal Medicine, and others have issued guidance regarding prenatal care during COVID-19 pandemic. Should be tailored for low versus high risk patients in order to reduce the exposure. For home care, most, at least 86% of patients with known or suspected COVID-19 have mild disease, don't warrant hospital level care in the absence of obstetric problem, like preterm labor, like BV bleeding, abortion. Patient instructions and other aspects of home care are similar to that non-pregnant person, except in the third trimester, we should perform fetal kick count, observation of and report decreased fetal movement, observation of labor. Okay. Medical and obstetric care for hospitalized patients. If the pregnant woman with mild disease plus comorbidity patient should be, or moderate or critical disease patient should be hospitalized. Pregnant hospitalized patient with severe disease and oxygen requirement plus comorbidities or critical disease should be cared for as a multidisciplinary manner. COVID-19 status alone is not necessarily a reason to transfer non-critically ill pregnant women with suspected or confirmed COVID-19. For fetal monitoring, the need and frequency for fetal tests depend on the gestational age, stability of maternal vital signs, oxygenation, and other maternal comorbidities. For monitoring of preterm labor, monitoring pregnant patients for signs and symptoms of preterm labor is routine component for obstetric care and should be a component for of maternal monitoring of pregnant patients hospitalized in non-obstetric setting. So our aim for if respiratory support is needed, the oxygen saturation should be maintained above 95%. The partial pressure of oxygen should be maintained above 70 milligram mercury because it will enhance the diffusion of oxygen from maternal side to fetal side. For the position, most of the ICU patients will be in prone position. We prefer like left lateral position to reduce the compression of inferior vena cava to enhance the venous return. If possible, we prefer left lateral position. If patients need permissive hypercapnia or ECMO, it doesn't harm to the fetus, but that is still limited. So the use of thromboprophylaxis, if not contraindicated, if the thromboprophylaxis is not contraindicated, like patient with bleeding or severe thrombocytopenia, we can give if patient has COVID-19. Either to choose low molecular weight heparin or unfractionated heparin. It depends on the situation. If the labor is imminent, we can give unfractionated heparin because shorter half-life and can be antidoted. If not, if the labor is not imminent, we can start Clexane, unless if there is any contraindication like bleeding or severe thrombocytopenia or other contraindication of pharmacological thromboprophylaxis. So, betamethasone, antenatal betamethasone, this is to enhance fetal lung maturity, is not contraindicated. We can give from 24 weeks up to 34 weeks. For pregnant patients between 34 and 36 weeks of gestation, the risk of preterm birth within 7 days, if we give the corticosteroid, the benefit of neonate are less clear, and ACOG has advised not administering a course of betamethasone to such patients. Only we give if between 24 weeks and 34 weeks. If there is an indication in pregnant lady for low dose aspirin, like prevention preeclampsia, any patient with vascular disease, SLE, diabetes, hypertension, aspirin, low dose aspirin can be given. There have been no clinical or population-based data that directly address risk of non-steroid anti-inflammatory drugs. Given the absence data, ACOG and European Medicine Agency recommended not avoiding non-steroids in COVID-19 patients when clinically indicated. For tuberculosis, the nifedipine is preferable because the nifedipine and I think atosiban are safe, because beta-mimetic agents will cause tachycardia, tachypnea, pulmonary edema should be avoided. For magnesium sulfate also should be given with caution regarding the effect, if the effect of toxicity for the also it will cause respiratory depression or cardiac depression. Magnesium sulfate will be given with caution. Okay. Follow-up of women recover from COVID-19. We will assess the we will assess the growth 14 days after symptoms, as there is risk of IUGR for the first or early second trimester after resolution. Anatomy scan can be done from 18 to 23 weeks. Suboptimal fetal growth due to placental insufficiency is possible because maternal COVID-19 has been associated with uteroplacental vascular malperfusion. Timing of delivery in infected women for non-severe illness. Delivery is not indicated and ideally will occur sometimes after a negative test result is obtained or isolation status is lifted, thereby minimizing the risk of postnatal transmission to the neonate. Women with preterm COVID-19 and non-severe illness who also have medical obstetric complications such as rupture of membrane, preeclampsia. The timing of delivery is generally determined by the usual protocol for the specific medical obstetric disorder. For severe critical illnesses, timing of delivery needs to be individualized. For hospitalized patients with COVID-19 with pneumonia but not intubated, some advise to deliver between 32 to 34 weeks, as the risk of prematurity also is less. Prematurity complication is less after 32 weeks. Timing of delivery of the hospitalized pregnant woman intubated and critically ill is challenging. After 32 to 34 weeks, some have advocate delivery if patient is stable to avoid any pregnancy-related problem if the maternal condition subsequently deteriorated, but this could exacerbate the maternal condition. Management of labor and delivery. The notification is important. Pregnant patients who have confirmed or suspected COVID-19 should notify obstetric unit before arrival. Screening also in ER for signs and symptoms is COVID-19 is mandatory. Use personal protective equipment on labor and delivery during active labor. In particular, there are concerns of viral dissemination when infected patient is forceful exhaling. Forceful exhaling may reduce the effectiveness of mask for containing respiratory droplets and preventing the spread of virus. Care of COVID-19 positive inpatient, they should be in negative, all patients should be in negative pressure room in antepartum, intrapartum, and postpartum COVID-19 only unit. Pregnant patients with suspected or confirmed COVID-19 are instructed to wear surgical mask during labor and delivery, which may be difficult during active pushing when the chance of aerosol generation are greatest. COVID-19 is not an indication or alter route of delivery. Usually, the decision of cesarean delivery or vaginal delivery is performed for standard obstetric indications. COVID-19 per se is not an indication for cesarean delivery. For analgesia and anesthesia during labor, neuroaxial anesthetic agent is not contraindicated, has several advantages in labor. It provides good analgesia and thus reduce cardiopulmonary stress from pain and anxiety. It is available in case of emergency cesarean section is required. For nitric oxide, the Society of Obstetric and Anesthesia and Perinatology suggests considering suspending use of nitrous oxide for labor analgesia in these patients because insufficient data about cleaning, filtering, and potential aerosolization of nitric oxide system. General anesthesia is considered an aerosolizing procedure, so special PPE like N95 mask should be worn by all involved healthcare providers during cesarean section. For labor management, for induction of labor, for patients who require cervical ripening, outpatient mechanical ripening with balloon catheter is an option. For inpatient, we prefer using two methods like mechanical and misoprostol or mechanical and oxytocin. It will decrease time from induction to delivery compared with using one agent only. If patient in labor, continuous CTG monitoring is mandatory for laboring ladies because there is frequent of non-reassuring tracing has been reported. During labor, the aggressive hydration should be avoided since it can lead to pulmonary edema and worse maternal oxygenation that may alter, that may already be compromised. Artificial rupture of membrane and internal fetal heart rate monitoring can be performed, but data are limited. Labor management, delivery procedures. ACOG has stated that delayed umbilical cord clamping is highly unlikely to increase risk of transmitting pathogen from an infected mother to the fetus. So delayed umbilical cord clamping is not contraindication. Intrapartum and postpartum fever, if patient develop fever postpartum, COVID-19 should be screened. Should be met in the differential diagnosis, particularly if accompanied by respiratory symptoms and reduced oxygenation. With the other differential diagnosis of postpartum pyrexia like chorioamnionitis and enteritis. For postpartum care, venous thromboembolism prophylaxis should be considered in postpartum. The decision based on individual risk assessments. Maternal monitoring for patients with known or suspected COVID-19 who is asymptomatic. Postpartum maternal monitoring is routine. For patients with moderate illness, continuous pulse oximeter monitoring for at least 24 hours or until improvement of signs and symptoms. For patients with severe or critical illness, very close maternal monitoring and care on the labor and delivery unit or intensive care units are indicated. For infant evaluation, the infants of mother with COVID-19 are considered COVID-19 suspected. And they should be tested, isolated from other health infants and cared for according to infection control precaution for patients with confirmed or suspected COVID-19. Repeat test approximately after 48 hours if the infant is still at the birth facility. mother to baby contact. The World Health Organization has opined that mother who have suspected, probable, or confirmed COVID-19 virus infection should be enabled to remain together and practice skin-to-skin contact. The CDC has advised determining whether to separate a mother with known or suspected COVID-19 and her infants on a case-by-case basis, using shared decision-making between the mother and clinical team. Factors considered include the mother and infant clinical condition, whether the mother infection is suspected or confirmed, and the infant testing results, the mother desire to breastfeed, the facility ability to accommodate mother-baby separation or collocation, the mother's ability to maintain separation when she goes home, if she has not met criteria to discontinue temporary separation. For postpartum care, after hospital discharge, a mother with symptomatic COVID-19 infection should maintain a distance for at least 6 feet from newborn and use face mask and hand hygiene for newborn care until at least 3 days have passed since recovery. For mother with laboratory confirmed COVID-19 have never been symptomatic, transmission precaution can be discontinued when at least 10 days have passed since the date of their first positive COVID-19 diagnostic. Breastfeeding and formula feeding. Although several small series reported that all samples of breast milk from mother with COVID-19 tested negative. There is a general consensus that breastfeeding should be encouraged because of its many maternal and infant benefits. In the setting of maternal COVID-19 infection, the infant may receive passive antibodies protection from the virus, since breast milk is a source of antibodies and other anti-infective factors. Analgesia, there is a concern nowadays about non-steroid anti-inflammatory drugs with COVID-19. Acetaminophen is the alternative. Discharge from hospital, early discharge postpartum, such as 1 day after vaginal delivery and maximum of 2 days after cesarean delivery, to limit the patient personal risk in hospital environments. Postpartum visits, modifying or reducing postpartum outpatient care is appropriate to reduce risk of an advertent exposure. Thank you. Do you have any question? Hello?
Thank you, Dr. Hussain. There is a question for you. How we can test a newborn baby for COVID infection?
Yeah, nasopharyngeal swab or rectal.
Swab.
Yeah, nasopharyngeal swab or rectal swab.
Okay. They are all thanking you, and I think if any more questions we can have in the chat room.
Okay.
I think they don't have any more questions. Thank you, Dr. Hazmi, for your contribution.
Thank you.
And now we'll be proceeding to our next speaker, Dr. Tasmia. She is the head of infection control and is doing a great job in making awareness for recommendations and the infection control precautions in this pandemic of COVID-19. And we'll have experience with her now how we can apply these precautions while we are dealing with the pregnant COVID-19 patients. Welcome, Dr. Tasmia.
Assalamu alaikum, everyone. Thank you, Dr. Saima, for the introduction. As already, I will be talking more about the infection control precautions that you need to take, especially when you're handling a COVID suspected or a confirmed case in pregnancy. So there's not much of a difference in how you deal with the normal and as well as the others. However, the precautions remain the same, but as Dr. Hazmi has already covered most of it, I will brief you about certain recommendations, especially regards breastfeeding and also some additional precautions, especially during labor. So to begin with, of course, I would like to say that as being frontliners and also healthcare providers, it is very, very important for us to actually know what kind of PPEs that you need to wear, the indication of its use, and also not to abuse the use of the N95 or any other personal protective equipment that are available. As you all know that there is a global shortage of all of these, hence it is very, very important that we use these PPE which are so valuable to us wisely. So to begin with, I will be covering the following: how to don your appropriate PPE, how to perform your hand hygiene, how you need to don and doff your personal protective equipment, because it actually matters. This is very, very important because the way you don and doff can also lead to contamination. So it is very, very important you know the sequence of it. And with this, we can safely and confidently care for the patients with confirmed or those with under investigation for COVID-19. Now, as already stated, the CDC guidelines recommend that you follow standard precautions, contact precautions, and airborne, especially if you are doing any aerosol generating procedures. Now, I will be talking elaborately on what are aerosol generating procedures and what are they and how you go about it a little later. However, for you at the moment, it's very important for you to know that you need to follow standard contact. In addition to the contact, you also need to follow droplet precautions. So whenever you do an aerosol generating procedure, it's then that you have to follow your airborne precautions. Now, hand washing is a single most important and easiest method for reducing the transmission of pathogens. However, if you don't have water available or sinks available at the point of patient care, it is at this time that you may use alcohol hand rub. Alcohol hand rubs are also found to be equally effective, and it is you could actually have a very high superior effect than hand washing. Also with this, you need to wash your hands, especially the recommendation to wash your hands is especially when it becomes soiled. But otherwise, if unavailable, if you have no facilities for hand hygiene, especially like availability of sinks and so on, you could go about doing it as alcohol drops. Now, it is also important to know when you need to do your hand hygiene or the moments of hand hygiene. These are before you touch a patient, before any clean or aseptic technique, after any body fluid exposure, after you touch a patient, and after you touch a patient's surroundings. So these are the 5 important moments when you really need to concentrate on hand hygiene. Now, how do you go about doing your hand hygiene? There are certain prerequisites that you need to meet. It is very, very important for you to remove all your jewelry if you are wearing them. Any rings, any gadgets, any watches, etc. needs to be removed. Your fingernails need to be cut short, and make sure that you go about doing it, and fold your apron or fold your scrubs to expose the wrist, because you also, there is a step wherein you need to cover your wrist area. So the first step includes taking a handful or palmful amount of the alcohol hand rub onto your palm and rubbing it palm to palm. Then the second step includes rubbing the palm to dorsum and vice versa on the other hand. The third is, of course, with your fingers interlaced, you try to rub your areas in between, the web spaces in between your fingers with friction. The fourth is rubbing your back of the fingers across your palm with the fingers interlocked. 5 would be to rub your thumb along with the web space of the thumb in a rotating motion on both your hands. 6, of course, with rubbing the fingertips to and fro in the forward and backward motion. And 7 is taking care of your wrist or rubbing your wrist. So with all of this, your hand hygiene is complete. So always remember that before you don your PPE as well, you need to first do your hand hygiene. Now, what is the duration that you would do your hand rub? The duration of hand rub, also remember that the sequence remains the same for both hand rub as well as hand hygiene. But the duration for which you do your hand rub is 20 to 30 seconds. Whereas when you do your hand hygiene, you need to spend at least double the time that you have spent for your hand rub, which is about 40 to 60 seconds. Okay, so take care that you spend this much of time, especially when you do your hand hygiene. Now, as healthcare providers and dealing with positive or suspected COVID pregnant patients, we also need to be N95 fit tested. So you need to do your N95 fit test, try to get the best fit that fits you, and then you try to use the mask, remember the size of the mask, and try to use the same one whenever you encounter such patients. Now, for those who have failed the N95 fit test with almost all the sizes, it is important that you use a popper, which is a powered air purified respirator, as you see it on your right side. Okay, this is a powered air purified respirator whereby you have a hood and there is a machine along with a HEPA filter, and this needs to be used especially when you're dealing with cases of suspected or confirmed COVID. Now, these are the common questions: how you prevent, or what are the prevention ways? Again, you need to avoid close contact with people who are sick with respiratory symptoms, avoid any crowded or closed areas, wash your hands regularly with water, especially when you do all kinds of activities. Try to avoid touching your eyes, nose, mouth without any washing your hands, and to cover your mouth and nose, especially during sneezing. Also, there are certain recommendations that you should not be eating undercooked meat, not to come in close contact with animals and animal products, and so on. Now, these are very simple etiquettes that you need to follow, especially when you are working with such patients. Avoid touching your eyes, nose, and mouth, especially with unwashed hands. Try to follow the cough etiquette, which includes covering your mouth and nose with a tissue, especially when you cough and sneeze, and to dispose of the tissue in the nearest waste receptacle directly after use. You then need to perform your hand hygiene after you have come in contact with the respiratory secretions. Now, many a times, a tissue may not be available at that point of time. In such cases, you can cough onto the elbow and then clean it once you have done with it. Now, it is also important to know what kind of PPEs to wear and when to wear such PPEs. Now, at the entry point of the hospital, remember that the universal masking is what is practiced. Whether you are working in clinical areas or whether you are in non-clinical areas, it is important for you to wear your mask. This is made universal because there has been a lot of cases of asymptomatic carriage as well, because people who are asymptomatic have also been known to transmit the virus, and hence it is recommended that all of you try to put on your mask. This mainly helps to contain the droplets or to contain the secretions and acts as a source control. Now, what happens when you are transferring a patient, maybe for a diagnostic procedure or some kind of, or another department, or you're transferring them to another place? In such cases, you need to put on the following PPEs. You need to wear your goggles, put on a surgical face mask, gloves, and a yellow gown. So remember, you are all wearing surgical gowns or you are wearing your surgical scrub suits. So You will have to wear a yellow gown over the surgical subsuit, especially when you are transferring such patients to other facilities. Now, if you are anticipating an aerosol, like for example, if the patient is intubated and if you suspect that there could be leakage from the circuit or accidental dislodgement of the circuit, it is very important for you to be wearing your N95 mask at this point. Now, there are certain aerosol generating procedures that you need to do. Intubation, for example, has been found to be maximum risk for the transmission of the virus to the healthcare workers. So whenever you are doing the aerosol generating procedures, which I will mention, the following PPEs need to be worn. So remember that you wear your goggles or your face shields, your N95 respirator mask. Again, it is very important that you wear the mask that has been fitted or which fits best. This has to be used and not any other. We need to wear your gloves as well as a surgical gown. The surgical gown is the blue gown that we use. So for all aerosol generating procedures, make sure that you use or put on the surgical gown. Now, how you put on your PPEs is also important. So first, do your hand hygiene. After you perform your hand hygiene with the following steps that I already mentioned, try to first check if all your PPEs are of appropriate size and if all are available, so that you could have someone fetch it for you before you actually go on to put your PPEs. Also, it is a recommended practice to have a buddy or to have an assistant to visualize what you have been wearing and to correct you if you have not followed the steps of the donning properly. So the first step is, of course, to put on your gown. Make sure that the purpose of wearing the gown is mainly to cover your attire. So make sure that the neck as well as the chest area is covered. Of course, if you're wearing a surgical mask, make sure that you have a metal piece which acts as the nose bridge, and then you have one tie which goes above the ear and the other at the nape of the neck. Now you have the third step, of course, which is the goggles. You could either wear goggles if available or a face shield, and four is the gloves. So whenever you are in the patient area or dealing with such patients, make sure you keep your hands away from the face. Never try to fiddle your PPE or never try to adjust your PPE. Limit touching surfaces to the minimum, and change gloves if they totally get contaminated, and perform your hand hygiene wherever you think you have contaminated yourself. Now, how you remove your personal protective equipment? Again, as we all know, the gloves are the most contaminated one. We follow the pinch and glove technique. You slide one finger beneath the glove, you remove it, and then you put on the other finger within the gloves and remove it in toto. So the second is, of course, we have the goggles or the face shield. So when you remove this, make sure you never touch the front surface of the goggles because they are already contaminated. Try to hold on to the band end from behind, try to snoop or try to bend down slightly and then remove it. Okay. And then the third, of course, is the gown, which you remove it. Try to remove it in such a way that because the outer surface is contaminated, you need to remove in such a way that the outside faces in and the inner out. So then try to roll it into a bundle. Try to wrap it in such a way that the outer surface becomes inside and the inner one outside, and you try to roll it into a bundle and you put it into the medical waste container, which is the yellow container. Now the fourth is, of course, we have the N95 mask. Never touch the front surface of the mask. Always grasp the bottom of the mask, bottom band of the mask, and then remove it, and then gradually remove the above one, and then you could dispose it. Okay. Now we have this policy of extended use and reuse that is followed in our KSMC. Now what you mean by extended use is you will be wearing the same N95 mask for the period or for a duration of about 4 to 6 hours and maximum of 8 hours. So of course this is going to be a little um, it is not tolerated or tolerated, probably it is not very comfortable for many of them. And even if tolerated, it's just for a few hours and not for a very long duration. However, if you are comfortable with this, you could use this. On top of the N95, you need to put on your surgical mask or the face shield. This is mainly to prevent the front surface of your mask from contamination. Now, the other thing which we find people using is the reuse policy. Now, by reuse, we mean that you're going to use or remove it. You will use this for at least 5 uses of such encounters with the patient. Now, what do you mean by reuse? Of course, you will be provided with a paper bag, which is a breathable bag. You will keep your mask inside, okay, and you will keep it there. Of course, you will have 5 uses or 5 boxes ticked on it, and with every use you will try to tick it. So with this, once you finish the 5 uses, you will discard the mask and use another mask for another mask. Now, if you have done an aerosol generating procedure, it is important that you discard the mask and use another new one. Okay, so these are the extended use and the reuse. Now, we have also started to reuse our face shields. So remember, you will be provided with a face shield with just one shift. You have one face shield, so you need to disinfect the front surface or by using wipes which are available. You can have alcohol wipes as well as hydrogen peroxide wipes, and you could use them for disinfection of your face shields as well. Now, as already stated, reporting of these suspected cases is very, very important. You need to report these suspected cases, especially by calling 937. These get registered in the Health Electronic Surveillance Network. Also, it is very important that all suspected patients get to do a nasopharyngeal swab, especially if they are spontaneously breathing, or you need to do a deep endotracheal aspirate, especially if they are intubated. Now, hand hygiene is very, very important, followed by the appropriate use of the personal protective equipment. It is also important that such symptomatic or suspected or confirmed cases are put on a face mask. This is mainly to act as a source control or to contain the cough. Now, following this, these patients with respiratory symptoms are done, they follow a checklist to score them. Once they meet a certain criteria or a score of more than 6, they are directed towards the triage and isolation and towards isolation rooms. Now, patient placement, as already stated, it is very important that they are placed in negative pressure rooms, the suspected cases as well as the confirmed. However, if you don't have them available, you need to place them in single room with a HEPA filter. Now, the HEPA filter needs to be kept at the head end of the patient, and try to minimize the number of people entering into the room, and also try to maintain a logbook so that if anyone gets infected or has developed signs and symptoms, it is easier for us to trace who has actually got in contact with these patients. Now, the following are the aerosol generating procedures like tracheal intubation, non-invasive ventilation, tracheostomies, CPR, doing manual ventilation before intubation, bronchoscopies, and so on. Now, healthcare workers performing aerosol generating procedures, make sure you have your appropriate size N95 mask available. The most important prerequisite is you should be N95 fit tested if you're doing an aerosol generating procedure. If not, you are not entitled to do an aerosol generating procedure. You should either use a popper to do the aerosol generating procedure. Now, also, once you have a N95 mask, make sure that you do appropriate seal check. Now, how you do a seal check is you will put on your fit tested N95 mask. You will try to mold on your nose piece of the N95 mask and exhale. So when you forcefully exhale, try to feel if there is any air escaping around the sides of your mask. Now, if there is air escaping, it means your mask is not fitted well. So you need to adjust again onto your nose piece, especially the molding. You try to mold over the nose piece and so on until you get on the best fit as possible. Now, you also need to use your face protection when you're doing aerosol generating procedures, and as already stated, surgical gowns or the blue gown, and make sure that you do it in a negative pressure room, especially with adequate air exchanges, or if you don't have a negative pressure room, try to do these procedures in a single room with a HEPA filter. Now, we also need to limit the movement of such patients, especially from one area to another. You need to use a designated X-ray equipment. try to use routes of transport which could be which could minimize the exposure to the staff. Like for example, when we are transferring our patients, especially to other like hotel accommodations or to other areas, we try to inform the security so that he keeps traffic away from the patient who is being transferred, so as to avoid exposure. Now, also ensure that the healthcare workers who are transporting wear appropriate PPEs as already described before, and you also need to notify the receiving area of all the precautions that you need to take and disinfect patient contact surfaces. Now, these are equipments which are dedicated only for COVID patients. So we need to dedicate our equipments like X-ray machines, dialysis machines, CPR machines. All of these are dedicated. They are not shared between patients, or if shared between the COVID patients, they need to be disinfected and labeled as clean for to be used for another patient. Now we also have elevators which are designated only for the transfer of COVID patients, so we need to make use of these elevators and so on. Now this, what you see, is the transport capsule. This is a negative pressure capsule. We try to make use of this, especially when we transfer such patients to other hospitals, and this is what we use for the safe transfer of such patients. Now, whenever you are transporting a patient, make sure if a patient is spontaneously breathing, you need to put on a face mask for the patient. Now, you need to put on an N95 mask, especially if the patient is intubated, and try to wear appropriate PPE as already stated. Once you reach the designated hospital, try to change on your PPE to a new set of PPEs, and then you need to clean the ambulance, you need to disinfect the ambulance, and then try to put on a new set of PPE before you actually get back to your hospital. Now, it is also important, some of the ambulances can also be negative pressure, so it's best to use the negative pressure ambulance. However, not all of them are equipped with negative pressure, so you may have to use other ambulances which are provided with HEPA filters and so on. Environmental cleaning is also very important. We need to dedicate equipments. First, it is important you need to have your own stethoscopes. Try to disinfect your stethoscopes between patients. Try to carry as minimal gadgets with you as possible. Do not carry your mobile phones or any other gadgets with you when you are working in the isolation areas. Blood pressure cuffs, thermometers are all dedicated for the patients. Also, it is important to routinely clean and disinfect the patient areas, also especially the high-touch surfaces, monitor surfaces, the floors, and so on, because there have been incidents of transmission taking place through contaminated surfaces. Of course, the general public recommendations I have already mentioned. The persons, especially with higher comorbidities and high-risk people, are more prone for it, and hence they need to take utmost care, especially when dealing with such. Healthcare workers exposed, again, when you have handled a case which is suspected or confirmed and you have developed signs and symptoms, you need to inform your direct supervisor about your signs and symptoms. You need to contact the infection control hotline, which is 19910. Try to inform the infection control team so that they would do your risk assessment, and you will be scheduled for an appointment for the swab based on your risk assessment. So it is very, very important for you to also monitor yourself for the 14 days for any clinical signs and symptom deterioration, and to keep your supervisor notified or the infection control personnel notified if you do so develop. Now, when you are in home isolation, this is very important. You need to follow your hand hygiene, especially before any activity like preparing food, eating, using the toilet before and after caring for an ill patient, and so on. Try to avoid unnecessary exposures to anyone who is sick. Try to dedicate your utensils, dishes, your towels, and so on. Follow cough etiquette and monitor everyone's health, that is your family's health, for any signs and symptoms. So it's very important that you practice social distancing, okay? And once you practice hand hygiene, respiratory etiquette, and so on. Now, patients exposed, you can have a patient who may be exposed to a positive case and may develop to signs and symptoms. So getting this exposure history is very, very important once you have such patients admitted to you, so that you could go about isolating them and monitoring them for any signs and symptoms for 14 days. So during these 14 days, you will monitor such patients for any signs and symptoms. And if you do suspect any deterioration in the clinical condition, you need to screen them for COVID. Now, there are some of the other, of course, these are related only to maternity. When you have a suspected case, it is important that you isolate them and not send them to general labor ward. During transfer to the isolated delivery room, precautions must be taken. That is, as already stated, make use of the appropriate PPEs, especially when you're transferring such patients. Reporting of such cases immediately to the MOH, according to the guidelines, also needs to be done. Now, delivery also should be done in isolated rooms, proper disinfection measures following the discharge caregivers handling such patients must take care of appropriate PPE. They must wash hands. They must change their clothing in between handling of two different patients. Now, newborn babies who are COVID-19 of the COVID-19 infected mothers should not be allowed to be in contact with their mothers till the mother is cured and declared free of the disease. So these are the MOH guidelines, what I'm talking about, in contrary to the other guidelines which were discussed earlier, that was WHO and CDC. So isolation of these babies until they are declared negative or cleared from the virus should be carried about for at least 14 days. Now, if the newborn is tested positive for the COVID-19, the newborn is kept in isolation until cured or tested negative. Now, the breast milk is, of course, the best nutrition to the newborn. However, direct breastfeeding is not advisable by the MOH because of the risk of direct infection with close contact. Extracted breast milk could be fed to the infant, especially using milk bottles with the help of another person. And precautionary measures need to be taken, like washing your hands, washing your breast, wearing a face mask, using a clean breast pump, clean the surface of the milk collection container, and allowing another person to feed the baby. So these are the infection control measures for the lactating woman, following respiratory hand hygiene, following hand hygiene, wearing on a mask, especially during breast expression, and so on. So these are very important. Routine cleaning and disinfectant of the surfaces is also important, and maintaining social distancing is also very, very important. So with this, I would like to end my talk. If you have any questions, you can just share it in the chat room.
Thank you, Dr. Tasmia. I think we don't have any question till now. I will suggest if we have any questions, it can be left in the chat room and we'll continue to answer because all of us are online.
Dr. Saima,
And
could I just ask one question to Dr. Azmi?
yes, sure.
Yes. Yes. Dr. Hazmi, Assalamu alaikum. Thank you for such a wonderful lecture. But I would just like to have some clarification from your side regarding the guidelines that you mentioned, the WHO as well as the CDC. These are contrary to what we have in our MOH guidelines, especially regarding physical separation between the mother and the neonate. So I would like to know, or if you could just share what your practice is otherwise in the maternity, it would be of help to us. I mean, what exactly have you been practicing as of now? Are you still separating the mother from the baby, and or are they still kept together? Are they breastfeeding? Are they being breastfed, and so on? I would like to hear from you and your experience, please.
Yeah, actually, it's shared according to the situation of the mother and the baby, but mostly we separated both. Yani, we separate the mother from the baby. the skin-to-skin contact is not allowed, especially if patient has moderate or severe disease. For the breastfeeding, I think يعني we prefer bottle. They can pump the breast milk and to give to the baby, but such cases should be individualized. Okay, the case different from another case, but we don't allow skin to skin contact. We separated the mother and the baby. Clear? My voice is clear?
Yes, doctor. Thank you so much.
So now we'll like to proceed towards the next lecture, which will be presented by Dr. Vadim. He's the head of the quality department and a very good speaker. And we'll be speaking about the airway management in a pregnant patient with query or confirmed COVID. Welcome, Dr. Vadim.
Assalamu alaikum. How are you, Dr. Saima? How are you, everyone? Dr. Saima, can I share my screen?
Yes, Dr. Vadim.
Okay. Good. Good. So, good evening, everyone. I'm going to have a very brief and summarized talk about actually two big issues, two big dilemmas, COVID and pregnant. Airway management in each one of these situations alone is a big topic, so we're going to have them overlapping. My name is Walid Al-Itrebi. I'm an ICU specialist, anesthesia background. At the beginning, I have nothing to disclose because I'll be playing some video clips. I have no copyright to. I have downloaded them from YouTube. So to begin with, I just want to review some epidemiology with you. In obstetrics, difficult intubation is more common than in non-obstetrics, almost double. And failed intubation occurs at a rate of 2.6 per thousand. Associated deaths occur at a rate of 2.3 per 100,000. So difficult airway management in a pregnant lady is more common than the non-pregnant. And there are some special reasons for that. Maybe you're all aware of that the pregnant lady goes through some physiological changes that lead to these problems. For example, in management of the airway, there's the problem of weight gain, increase in the breast size, the congested and hyperemic mucosa of the upper airway. All these make it difficult to position laryngoscopes, position tubes or airways, and might induce trauma. However, more importantly, the pregnant lady desaturates quickly. And this is a very crucial point. The easy desaturation of the pregnant lady is because of the reduced residual functional residual capacity, because of her increased metabolic rate. Add to that a pregnant has a lower decreased tone of the esophageal sphincter and delayed gastric emptying. So adding to your problems the possibility of vomiting and aspiration. So what should we do? How should we proceed with the airway management of a pregnant lady? Well, I always advise for good assessment. Always have a good look at your patient. Try to anticipate difficulties. Try to see where problems might arise from. So have a look at her body mass index. Is she obese or not? Take a look at her neck circumference. Try to measure the thyromental distance, the distance between the thyroid cartilage and the chin. Forget about the myelopathy and the cricoid pressure, but try to examine or see her neck and head movement. Can she flex and extend her neck easily, or does she have a problem with that? Most important is her mouth opening. Have her open her mouth as wide as she can and have a look at the mouth opening. Is it going to facilitate airway management, or there's going to be a problem with that? So proper assessment is always advised in any airway management, and in particular the pregnant. You're all aware of this. Try to decrease the risk of or the damage if pulmonary aspiration due to vomiting happens. You can use H2 blockers, and you can use also any kind of antacid, sodium citrate. I think in our maternity hospital we use aluminum hydroxide. I'm not sure, but antacids in general, so that you increase the pH of the gastric content. Positioning of the pregnant lady is essential or vital when you're managing her airway. A position like this is not recommended. This is completely wrong. The proper position is like this. What is the difference? You can see here that the head is elevated, actually 20 to 30 degrees, what they call in a ramp position, and have the external auditory meatus at the same level of the suprasternal notch. This is a proper position for the management of the airway of a pregnant lady. Now then comes the question of, do we mask ventilate a pregnant or not? Well, those of you who are going to say no are actually correct, because if you bag mask the pregnant lady, we just said there is a high possibility or high risk of vomiting and aspiration. But those of you who are going to say yes are also correct. So if we mask ventilate the lady with not so much high pressure, less than 20 centimeters of water, then we might not induce vomiting and get the benefit of oxygenation, because we also just said that the pregnant lady desaturates quickly. So it's actually a debate, and it's never settled, and it depends on your patient, which is more serious in your opinion for this particular patient. Laryngeal mask airway versus endotracheal tube. Which one is better? Of course, the recommended airway management device, the golden standard, is the endotracheal tube. But I'll have you know that I have seen my professors perform cesarean section, anesthetize the patient completely throughout the procedure on laryngeal mask airway. However, it is reserved for the more elective cases. We are completely sure that they have an empty stomach, and particularly the slim body build. But the golden standard is the endotracheal tube. Okay, so now maybe you have noticed that so far I've been talking about a pregnant lady managing her airway in the OR. But that's maybe not your main concern as obstetricians. What if the patient crashes in the labor room or in the ER? So we're going to go very quickly through ways to maintain her airway. These are two famous methods in which you only use your hands. You don't use any instruments. And I think we have all practiced them in BLS. This is the jaw thrust, and this is the head tilt chin lift. I just want to remind you that in both these methods, when you use your hands and your fingers, use them on the bone. Be careful, don't press on the soft tissue. If you press on the soft tissue, you're actually blocking the airway. You can use an oropharyngeal airway. I am also sure that you have all used this and have seen it before. Oropharyngeal airways go through the mouth. So they are made of hard plastic so that if the patient bites or closes her mouth, she doesn't obstruct it. And don't worry about choosing the proper size of an oropharyngeal airway, because we use this rough method to tell us whether this OPA fits the patient. Have it side by side of the mouth, and the tip should end at the angle of the lower mandible. I'll play a very small clip on insertion.
The angle of the patient's jaw. So I'm going to place the end of the OPA against the angle of the patient's jaw and have a look at the angle across where the patient's incisors are. So we're going for the level of the patient's incisors, which looks to be around about the right level for this size OPA and this patient. We then need to have a think about inserting the OPA. So to do that, we're going to invert it. So essentially turn it upside down and insert it into the patient's mouth against their hard palate, rotate it around, and then locate it into the airway, nicely into the oropharynx. So we're going to invert, insert, rotate, and locate. And that should give us a nice secure airway all the way through without the tongue flopping back against the soft palate at the back of the mouth.
So the oropharyngeal airway goes in the other direction, upside down if you wish. And the reason for that is that you want to avoid the tongue. Then, if it's not successful, you can use its cousin, the nasopharyngeal airway. Now, the nasopharyngeal airway goes through the nose. And going through the nose above the hard palate, it completely avoids the mouth. And that's why we don't need it of hard plastic. Nasopharyngeals are made of very soft rubber. And you also don't have to worry about choosing the proper size, because we use this rough method to tell us if it fits the patient. Now, this time you start at the nose, and the tip of the nasopharyngeal airway should end at the ear lobule. Another clip on the insertion of the nasopharyngeal.
We're going to face that towards the patient's septum. So in this case, if we go into the right nostril, facing the bevel towards the septum, and we're essentially just going to push it vertically down into the patient's airway, allowing it to follow the anatomical curve of the airway round to end up at the bottom of the nasopharynx. You can insert it into either nostril, and it's normally going to be into whichever nostril happens to be largest.
So the nasopharyngeal, you can insert it following the anatomical curvature, because, as we said, we don't have the tongue here in our way. I put this picture to show you how much a nasopharyngeal airway is tolerated by a conscious patient. And it is the airway of choice when your patient has some level of consciousness and intact reflexes and intact gag reflex. So a patient with intact gag reflex, don't try the oropharyngeal. Use the nasopharyngeal airway. What if both of them are not successful? Then you use their third cousin, which is the laryngeal mask airway. And I'm sure by now you expect what should come here. There should be a rough method to tell us what size fits which patient. Actually, it's not a rough method, it's an exact method. Okay, Dr. Sarah, can we have all the questions at the end, please? So the method here is actually exact. It's written on the back of any laryngeal mask airway. It is written on it the weight, the body weight range that this LMA fits. So if you look at the laryngeal mask airway in your hand, you will find written on it the body weight range. For example, this picture says 30 to 50 kilograms. So you know that this LMA fits a patient from 30 to 50 kilograms. Actually, the laryngeal mask airway has more information written on it. For example, the volume of air that you need to inject in this elliptical shaped balloon in order to create a seal, to have it fully inflated. For example, in this instance, it says less than 20 ml. And there's a third piece of information, which is this black line. You can see it. This black line is running throughout the shaft on the back of the LMA. The importance of this line is that after inserting the LMA, when you need to align this black line with the nasal septum of the patient or the upper middle incisors. This way you are sure that it is exactly midline, and thus the elliptical shaped balloon is facing the larynx. This is how an LMA looks when it is in place. It's going through the mouth and the elliptical shaped balloon is facing the larynx. And when we inflate it using this syringe, we create a seal. So I'll have you watch this clip on insertion. This is only one of the methods of insertion. There are several techniques, but basically they are all the same. Completely deflate the elliptical shaped balloon. You go blindly using your index finger to press the LMA against the hard palate, and you go as far as your index finger allows you. Then you inflate the balloon. So this was the insertion of the LMA, but as I told you, none of these airways is the golden standard. The golden standard of airway management is the endotracheal tube. Now, I know that most of you now are thinking, now this is not our field, this is not for us. Well, I disagree. I believe that any physician who works with patients at a risk of crashing at any time should know how to intubate. So allow me to give you a very quick crash course on endotracheal intubation. This is the endotracheal tube, and the endotracheal tube is simply a shaft. This is the patient's side. Here we have a balloon, we call it the cuff, that you inflate through this side port. Once you have it inflated inside the trachea, it creates a seal. And this is your side where you have the universal connector that connects to a ventilator, an anesthesia machine, an ambu bag, anywhere in the world. It's called the universal connector. The most important thing is written here on the endotracheal tube. It says, for example, in this picture, ID 8. This stands for internal diameter of 8 millimeters. And this is what you hear anesthesiologists all the time saying, give me tube 7, give me tube 6. This is what they're talking about, internal diameter of 8. For your patient, the obstetric patient, I would use starting from 6.5 up to perhaps 8, depends on the body build of the patient. This is what you want to visualize so that you can insert the tube in. This is the vocal cords, and in between them is the glottis or glottic aperture. Beyond that, you have the trachea. You can see the tracheal rings here. So this is what you want to visualize so that you can insert the tube in. But there's only one problem. There is no direct line of vision between your eyes and the vocal cords or the glottic aperture. And that's why we have to use some other instrument to visualize the vocal cords. And this is classically used to be the laryngoscope. Laryngoscopes come in different shapes and styles, some of them with modifications, but basically they are of two types. The Macintosh laryngoscope, because it has a curved blade, while the Miller has a straight blade. This is the main big difference between them. And then there was some advancements where they changed in the laryngoscope the light bulb. They put a camera instead, and the camera displays on a monitor. This is the video laryngoscope, or sometimes for simplicity, we call it glidoscope. This is another video glidoscope, laryngoscope, but it has a small monitor on top of the handle that displays for you the view. Then there's, of course, the fiber optic laryngoscope, but this is beyond the talk. I just want to give you a very important tip if you are intubating a patient using a curved blade. And typically you use a curved blade with Macintosh, and if you are using the glidoscope. When you are using a curved blade, there's a specific point you want to insert the blade in, and anatomically this point is called the vallicula. The vallicula is the common base of the tongue. This is the tongue here, and the epiglottis. And the reason you want the blade there is that there's a small ligament here. It's called hyoepiglottic ligament. When you press on that ligament with the tip of the blade, it lifts up the epiglottis. It raises the epiglottis, as you can see here, revealing what's beneath it. And what's beneath the epiglottis is the vocal cords. So when you are using a curved blade, always make sure that you insert it in the vallicula. And how do you do that? If it's correctly placed in the vallicula, you don't get to see the tongue, but you do see the epiglottis. So if you don't see the epiglottis when you're intubating, then you are not placing it in the proper place. This is a very small clip that takes you through the anatomical landmarks when you are intubating.
I'm going to place the glidoscope inside the patient. Now, obviously, you can kind of see there's the patient's nose, lips, right here, the teeth. Now, as we go midline, you can see there's the hard palate right over here. Right behind the hard palate is the soft palate. And just below that, as we progress in, there's the uvula and the palatoglossal arches. Behind that, there's the pharynx. So this is the posterior wall of the oral pharynx. And as we go a little bit deeper yet, switch the stylet around, here's the tongue, right there. That's the tongue. Go a little bit deeper, that's the tip of the epiglottis. And in between the base of the tongue and the epiglottis, that space in there is the vallecula. So if you're using a Macintosh blade, you want the Macintosh blade to wind up right inside here. And essentially when you're using the glidoscope, that's roughly the same spot you want the glidoscope tip to reach as well. But remember, unlike a Macintosh blade, with the glidoscope, you're going in midline. With the Macintosh blade, you're going in on the patient's right side and then scooping the tongue out of the way into the patient's left side so you can visualize the glottis. So if we progress a little bit further down yet, there you can really see the epiglottis. There. The blade tips in the vallecula. Now here's the structures of the larynx that we're looking for. Right over here, you'll see the vocal cords, one there, and the space in between here is your glottis. So when you're intubating the patient, what you want the endotracheal tube to do is to pass between the vocal cords when the vocal cords are open, right? And place the endotracheal tube down here in the trachea. So that's the trachea down here. You can kind of see with the intubation head those tracheal rings at the top. So that is the trachea. You don't want the endotracheal tube to go down here because this area here, that is the esophagus. Okay, so once you've got this visualization right over here, what you need to do is grab your endotracheal tube and then insert the endotracheal tube into the patient's airway like so. And you can kind of see where the cuff is against the cords right here. Further advance the tube another centimeter to 2 centimeters, and 2 centimeters is ideal. like so. And then when you've got the endotracheal tube in the proper position, of course, remove the stylet while maintaining the same position of the endotracheal tube. At that point in time, your laryngoscope can come out.
So if anyone of you is interested later on when this COVID issue is over, we can have an actual training on our mannequin in the ICU. You are most welcome. So now let's talk a little bit COVID. I will walk you through this small algorithm of COVID airway management. We'll break it into pieces in a while. So the first part is the name of the algorithm, and it's very important in my opinion. It tells you two important things. The first thing, it's an emergency and rapid sequence intubation. So even if the patient is elective, but with COVID, you are doing an intubation that is emergency and rapid. And the reason for that is that you want to minimize the time to which you are exposed to the patient. You want to minimize the aerosol generation. And at the same time, a COVID patient, remember, being mainly a respiratory problem, desaturates easily. Add to that, that the patient is a pregnant lady who desaturates easily, so you want to make it as quick as possible. But the key to success is good preparation. Good preparation in everything. Preparation in the environment itself, the surroundings. Make sure you have all your medications ready, all your instruments that you might need ready. Preparation for the patient herself regarding her positioning and pre-oxygenation. Preparation of yourself and the team working with you with regards to PPE. And I want to stress on that. Dr. Tasmiyah mentioned this. I want to emphasize that. I read one article that says there is no emergencies in pandemic. What it meant is that if the patient is COVID, don't be a hero. When you see the patient, for example, crashing or desaturating, don't jump into the room and saying, I'm saving his life. No, protect yourself first. First, put on your complete protection, then go and save the patient. Don't try to be a hero. So it's a rapid intubation, a very short procedure, but to be successful, there should be good preparation. And in KSMC, we have developed the team for intubation of COVID patients. It is similar to the team formation almost everywhere in the world. I'm showing you a clip from another place, but it's very similar to ours. So perhaps you saw that the team formation most commonly is 3 members. The most senior, or the one with the most experience in airway management, handles the airway actually, and 2 are assisting him. In this picture, there's a 4th member, and as you can see, he is not in PPE because he stays outside the room. They call him, in this team, they call him the clean person. And his purpose is to run and get them assistance or help or to fetch something that they forgot to prepare. But I hope you noticed in the previous video how everything should be prepared and ready, and everyone in the team knows his or her role before we start the procedure so that we can make it swift as it is recommended. When you are managing the airway of a COVID patient, it is recommended to pre-oxygenate. However, this pre-oxygenation should be without positive pressure, without bagging. It should be by the flow of oxygen itself. And the reason for that is to decrease the aerosol generation. If you have to ventilate the patient actively or with pressure, we'll come to that and how to perform it. But it is recommended to be without active bagging. As you can see, the intubation is recommended to be with the video laryngoscope or the glidoscope. So this is so that you can stay away as much as you can from the patient. With the classical laryngoscope, you have to come closer than this and you expose yourself to aerosols. It is very important that before you connect the ventilator to the patient after intubation, you must inflate the cuff inside the trachea and create the seal. Once more, decreased aerosols generated. If you have to disconnect the patient to put her, for example, on a portable, suppose you're taking her from the OR to the ICU and you want to disconnect the anesthesia machine and connect the portable ventilator, you have to clamp the endotracheal tube. And the endotracheal tube should be clamped in inspiration, then you disconnect. Again, decrease aerosol generation. I just told you about the pre-oxygenation. It should be passive or without active bagging. But if you have to, if the patient is desaturating, and like most of the obstetric patients will desaturate easily, then it has to be a two-person procedure. As you can see, 4 hands. One person tightly fits the mask so that no saliva escapes, and the other one is doing the bagging. However, the way this person is handling the mask is not the recommended way with COVID patients. This is the recommended way to hold the mask in general. This is what we learned actually in BLS. It's called C and E, because these 2 fingers are forming a C shape and these 3 fingers are forming the letter E. This is the recommended way to handle the mask in general. But in COVID, it is recommended to hold the mask like this. This is called the V shape. The 2 thumbs are supposed to form a V shape. And the reason for that is that this part of your palm is much stronger than when you are using just your index and your thumb. So you want more power and more force to tightly fit the mask so that no secretions escape. So let's go back to the algorithm. We have done our good preparation. We have prepared everything, including ourselves, with regards to PPE, instruments, medication. We positioned the patient. We gave her pre-oxygenation. Then we try to intubate. If we are successful in our first attempt to intubate, well, that's very good. The procedure is done. We secure the tube and that's it. But the problem is, what if we fail our first attempt to intubate? We just talked that a pregnant lady has some physiological changes that might make intubation more difficult. So we can fail our first attempt of intubation. If this happens, then we should ask ourselves a very important question. Okay, I failed to intubate, but can I still oxygenate the patient? Am I still able to give her oxygen through the face mask, or even sometimes using a laryngeal mask, what we call here supraglottic device? This is the laryngeal mask airway. Can I still oxygenate her? If your answer to this question is yes, then you can relax a little bit because you're not going to lose the patient. You couldn't intubate, yes, but you can still give her oxygen. So you can be a little bit relaxed and you start to think what next. What comes next depends on your decision. Should you have another attempt of intubation? But when you try a second attempt, you should optimize the situation. You are the same, the patient is the same, so you must change something. Like, for example, use a larger blade of the laryngoscope. If you are not using it already, use a glidoscope, use a stylet on the tube. There are different things that you might think of that can optimize the situation. But if you think that you have done all these things already, and on your first failed attempt, you encounter difficulty that you do not think these optimization will solve, then think of the exit option, the way out of this situation, which is either using some bridge, I mean to oxygenate the patient until assistance arrives, like using the supraglottic device, the laryngeal mask airway. If this is not an option to you or not available to you, then you should start thinking of the surgical airway, which is obtaining a secure airway through a surgical procedure that we call cricothyrotomy. I will show it to you in a minute. And the recommended cricothyrotomy procedure here is bougie assisted because it is the fastest and the quickest. Now let's go back here where we failed our first attempt and ask ourselves, can we still oxygenate the patient? What if your answer to this question is no, I cannot oxygenate the patient as well? Now this is a real critical situation, very serious. What we call cannot intubate, cannot ventilate. So if this lasts longer than it should, you might lose your patient. There's no time if you are in this part of the algorithm. You have to act quickly. You might consider another attempt of intubation, again with optimization. More importantly is calling for help if you have not already done so here. If you have not already called for help after the failed first attempt, now is the time to call for help. And you should think quickly whether it's a situation for surgical airway like the bougie-assisted cricothyrotomy. With the bougie-assisted cricothyrotomy, I will finish my talk. Notice that it is done by military personnel because this is a very quick method of obtaining an airway. It's usually used in the battlefield.
Cric is indicated. You will start by preparing your equipment. Inflate the bulb with 10 cc's of air, looking for any leaks. Ensure you have your scalpel close by.
And prepare your bougie.
And then you'll use the head tilt chin lift method to visualize the larynx. From there, with your non-dominant hand, you'll place the larynx in between your thumb and first finger, and then palpate for the cricothyroid membrane. Once you have your site selected, you'll prep with either an alcohol wipe or iodine. And again, stabilizing, this can move quite a bit. So you need to apply a little bit of pressure and make sure that the head is nice and extended. From here, we'll make a vertical incision from the top of the cricothyroid membrane to the bottom. And so, as you apply enough pressure, that skin will naturally flay open, and then you'll be able to see the cricothyroid membrane. With that, you'll make a horizontal cut, and you'll place your trach hook. And I'm using anterior pressure to visualize the trachea. You'll insert your bougie into the trachea. You'll receive tactile feedback to ensure placement, and you'll be able to feel the tracheal rings as you advance your bougie into the airway. Once the bougie is inserted, you'll remove your trach hook, and then slide the tube down the bougie into the airway. Once your tube is all the way inserted, you go ahead and remove your bougie and inflate your bulb with 10 cc's of air. So once your tube is in place and you've inflated the cuff, suction to ensure that the lumen is clear. You look at the tube, you confirm if you have misting on the tube or bilateral rise and fall of the chest if the patient is unresponsive. If you have someone to help you, you'll secure a BVM and use a stethoscope. You'll listen to the epigastric region as well as visualize bilateral rise and fall of the chest and listen to both lung fields. Once you've confirmed a compliant airway, you'll go ahead and secure the tube to the patient. And once you've secured your crank, you will reassess.
So with that, I conclude. I hope it was interesting to you, and I'm open now for questions. While I was talking, there was a question from Sarah. Sarah, perhaps now you want to ask your question? Okay, so we don't have any questions. Then thank you very much, and I hope you enjoyed it.
Thank you, Dr. Waleed. Yeah, thank you, Dr. Waleed. It was very nice talk. Very impressive, like always, as expected from you.
Thanks a lot.
Yeah. I think there are no more questions. If there will be any, then we'll like to have in the chat box so we can answer later.
Absolutely.
Yeah. Thank you, Dr. Waleed. So
Thank you very
think, yes. So I think we'll move towards the next speaker now. Dr. Bashir. He's a senior clinical pharmacist, expert with his field, and he's going to speak about the pharmacology related to COVID-19 in pregnancy. Welcome, Dr. Bashir.
Thank you, Dr. Saima. I will start sharing my slides. Okay. Is it okay now?
Yes, you can proceed.
Okay, thank you very much. Thank you for having me today. I'm Dr. Bashir Abdurrahman, ICU clinical pharmacist. I will try to answer some of your questions regarding medications we are using with COVID-19. The first question I need to answer is there is any special regimen for COVID-19 pregnant women? Unfortunately, no. We don't have any special regimen regarding to those specific or special patients. What we are doing, we are avoiding as much as we can the use of antivirals and other regimens for COVID-19 by doing the maximum support we are able to do. But if we have to decide according to the risk benefit, and we will talk about this within the slides later. So specific regimens, there is no specific regimen, but you will go to the adult regimens. So we will consider our adult usual regimen. So initially, I will start talking a little about the virus itself. It's the structure. I will try to minimize this. Okay. The structure of the receptor binding gene region is very similar to that with SARS coronavirus. That's why we can name it by SARS-2. And the angiotensin converting enzyme 2 receptor is the main receptors the virus will bind to, and it will enter the cell. So there is many questions regarding ACE inhibitors and ARBs. The most important thing is to continue the medication. It's not antiviral and it's not anti-COVID-19 drugs. So we are not using those drugs for any patients with COVID-19 unless those patients already ongoing on those medications. So we will resume those medications for those patients to reduce the entering of the virus. There is some explanation that patients are using ACE inhibitors and ARBs. They have over expression and high expression rate of the those receptors. So if you will stop those medications for the patient, this will make maybe a high entrance for the virus, and it will make the more severe symptoms. What's the main issue regarding this virus? Of course, it's the spreadness. So why that much we are suffering from the spreadness? Because unfortunately, it's positive sense RNA and enveloped virus. That means it's very easy to attach and replicate, but it's not easy to treat. Regarding severe illness, usually we know that with those patients with advanced age and with comorbidities, but it's not exclusive for those patients. With our experience now, we can see a lot of young patients without any comorbidities, and also they have a severe and critical illness. But regarding comorbidities, it's a common or a common sense that those patients with some other disease, maybe immunodeficient patients, and those with cardiac problems, maybe those patients will be sicker than others. Another thing, those with comorbidities, sometimes with chronic liver disease or with acute kidney injury or chronic kidney injury, those will prevent us or prohibit us to use some regimens with those patients. So maybe they also have more severe illness. Why we are not finding medication for this one? Usually for if they approved medication, we need at least 12 years, but we have something called fast track approval. Even we will, even if we try to have this medication, unless we have safety and efficacy studies, we cannot give the fast track approval. So at least we need 1 or 2 years for the fast track approval and 12 years for the full FDA approval. I will go quickly to the management. We have 2 types of managements. We have the home care and we have hospital care. Home care, main thing is to focus on prevention of transmission to others and monitoring the clinical deterioration if occur, especially with those pregnant women. Regarding outpatient management, symptomatic management, good hydration, antibiotics, and analgesics if allowed and if necessary. For, as I mentioned, non-pregnant women, for pregnant and non-pregnant, almost the same with the home care. The only thing that in the third trimester, pregnant woman more fetal kick counts monitoring and report decreased fetal. They will report also the fetal movement, not only symptoms on the mother. For hyperthermia, of course, we have to prevent with the home care management, especially for the organogenesis time in the first trimester. Of course, with hyperthermia, we may have neural tube defects or miscarriage. So acetaminophen can be used, especially oral form. It's safe during pregnancy. For IV, we will use when we have to. Regarding hospital care, as I mentioned, we are trying to avoid medications as much as possible, so supportive therapy. But if failed, we need to weigh the fetal harm and mother benefit. And we have, let's say, multidisciplinary opinions and decision to start pharmacological treatment, because unfortunately most of our current options, they are not fully approved, and we don't know the efficacy till now, the absolute benefit of those medications, and most of them teratogenic and harmful for pregnant women. So regarding hospital care, we have many options for non-pregnant, and I will comment regarding to the pregnancy on those. We have glucocorticosteroids and nebulized medications, NSAIDs, antimalarial, antiviral, interleukin-6 pathway inhibitor, and convalescent plasma, plus some supplements. So we have something to reduce the signs and symptoms and to relieve those signs and symptoms, and others to reduce the complications of COVID-19. Some antivirals, we hope that they will reduce the severity of illness and will fight the COVID-19 itself. And we have other supportive therapies. Corticosteroids, we have bad experience by increasing mortality with influenza and delay viral clearance with MERS-CoV. But a few days ago, we had this big British study. It mentioned that starting corticosteroids for those patients with severe to critical illness, that means with respiratory symptoms, with the desaturation, it may improve mortality and reduce, it may reduce mortality by a good portion. So we are using now corticosteroids only for not only symptomatic, but there is some respiratory symptoms with severe to critical illness only. Regarding those patients using corticosteroids for let's say COPD or asthma, there is a recommendation they can continue their chronic medications, and if there's an exacerbation, also corticosteroids can be used. But for the sake of COVID-19, we have to use those medications for severe to critical patients. That's why for ARDS and septic shock, we are using those medications. For non-pregnant women, dexamethasone 6 mg once daily for 10 days. But for pregnant and breastfeeding, we are choosing those drugs, corticosteroid not crossing the placenta. So prednisolone 40 mg per oral or IV hydrocortisone 80 mg twice daily we can give. So we are avoiding using dexamethasone and we are using prednisolone oral or IV hydrocortisone. For nebulized medications, it's not also a choice for COVID-19, but for chronic use or adjunctive use, you can use metered dose inhaler if available, but if not available, for the healthcare providers' sake, usually we are stopping all adjunctive therapies like those antibiotics or immunolytic agents. We are trying to stop those adjunctive therapy and no need to use aerosol generating agents. For NSAIDs, I think 3 months ago, WHO sent us this warning that using ibuprofen or NSAIDs in general will increase the risk of severe disease and severe illness, especially for young patients. This French clinicians, they mentioned that they noticed that a few young patients who received NSAIDs early, they experienced severe disease. But later on with data, we found that there is no relation between those drugs and COVID-19 and disease severity. So by EMA, which is the European Medicines Agency, and WHO, they do not recommend to avoid those medications during COVID-19 infection. But we have some limitations that you will use acetaminophen as the first agent, and if failed, we will use lowest effective dose of NSAIDs. But for those patients using NSAIDs for rheumatoid arthritis or any other condition as a chronic medication, they can continue regardless there is COVID-19 or not. And they will stop only if there is major side effect like GI bleeding or renal impairment, acute renal impairment, as any other patient. Regarding pregnancy, NSAIDs, mainly we are talking here about aspirin. So low dose aspirin sometimes is indicated as prophylaxis for some patients for preeclampsia, but for critical and severely ill and critical patients, it's not worthy, and we can stop low dose aspirin. As I mentioned, the International Institute of Health has stated that persons with COVID-19 who are taking NSAIDs, they can continue with it regardless to the disease. Regarding anti-malarial drugs, we are using hydroxychloroquine and sometimes chloroquine. Usually, we are using also to manage and minimize symptoms of inflammatory immune diseases like lupus and rheumatoid. In vitro, they found those drugs can prevent the SARS-CoV and SARS-CoV-2 viruses from attaching and entering cells. That's why we still here in MOH, Saudi MOH protocol, we still use it for mild to moderate symptoms and mild to moderate disease early start, but after that for severely ill or critically ill patients we are not using hydroxychloroquine anymore. Regarding the safety, there is many issues regarding ocular and cardio hematological side effects. So for those patients asymptomatic or there is no respiratory symptoms, there is no need to introduce them to the QT prolongation risk if we have a QTC greater than 500. So if you have a young patient without severe symptoms and or without respiratory symptoms and there is a QT prolongation, no need to give those agents. But if you have immunodeficient or advanced age with comorbidities and you want to give according to the MOH protocol, you can start and you will weigh risk benefit. Regarding those two agents, hydroxychloroquine appears to have more potent antiviral. It has before the FDA emergency approval or authorization, but now it's withdrawn. And according to some data, there was no benefit of using hydroxychloroquine or chloroquine. As I mentioned, we still have it in MOH guidelines. So regarding the dose, 800 milligram day one, then 400 milligram daily for 5 to 7 days. If we will use chloroquine, it's 1 gram daily, then 500 milligram in day one, then 500 milligram daily. Regarding toxicity, about 90 patients will not show any toxicity with hydroxychloroquine, so you have the green light to go with it. But for others, we have again to weigh the benefit risk, and we have to decrease the incidence by reducing other agents may cause QT prolongation, or other agents may affect retina, and it will get the case. Regarding hydroxychloroquine in general, and especially in pregnancy, till now insufficient data, and many of the randomized study or trials showed there is no benefit of using hydroxychloroquine. So even it's there in the MOH, but according to the IDSA and the up-to-date they mentioned there is no need to use it and to introduce the patient for extra risk, while there is no benefit of using those agents. But anyway, we have to monitor toxicity if we will use it, and mainly we are talking about the QT prolongation. There is the graph that or the figure. You can see when you are safe to start hydroxychloroquine, or you have to consult cardiology first. Here, if you have QRS less than 120 and QTC less than 470, so you can start immediately. But if you have a QTC more than 500, you have to consult cardiologist. But if QRS prolonged more than 120, so QTC less than 520, you can start immediately. But QTC more than 550, you have to consult cardiologist. Daily, you have to check ECG and QT, and if there is any increment more than 550, you have to stop the medication. And if there is any increase by more than 50 milliseconds, of course, you have to stop also the medication. This is another figure, but the only thing I want you to concentrate that you have to optimize electrolytes before you are giving and checking the chloroquines and other medications. So you have to check magnesium and potassium and to optimize the readings. common side ophthalmic retinopathy, hematological and oncological, like hemolysis, especially for those patients with the chloroquine, not hydroxychloroquine. Usually, if we will use chloroquine, you have to send G6PD test. Leukopenia and thrombocytopenia also common. Endocrine, it's very important issue if you use those medication. With insulin, if your patient already on insulin, you have to reduce the doses of insulin you are giving to the patient. That usually we can see hypoglycemia. Of course, QT prolongation and ECG changes with cardiovascular, hepatic, abnormal hepatic function test, and acute hepatic failure. I think everyone heard about this Lancet study, that we have a huge study with 90,000 patients. Almost 15,000 of those patients had received hydroxychloroquine, and there was a worsening outcome, high risk of intubation, and more death and high mortality with the hydroxychloroquine arm. But later on, the sub-analysis and multivariate analysis comparing those patients with a propensity score, they found there was no association between hydroxychloroquine and intubation or death. So it's not harmful according to the, as mentioned above with previously with the study, but also there was no benefit. Regarding final slide or the last slide regarding hydroxychloroquine with the pregnancy, we have no benefit, so there is no clear evidence to be used. We need to outweigh risk benefit, as I mentioned, but unfortunately we don't have any evidence of to have any benefit of those medications. Regarding the, it will cross, of course, the placenta and the accumulation fetal ocular tissue in the animal studies, but has not been observed in human. So we can use it in other for other indications like lupus and for as a prevention of malaria. We still can use it, but for our indication here, COVID-19, we don't have enough data. The only data we have, it's not effective and there is no benefit. Remdesivir, the new agent, this is a broad spectrum antiviral activity against, of course, SARS, MERS, and there's some data regarding to Ebola. We usually using this as IV 200 milligram stat, then 100 milligram OD for 2 to 10 days. But unfortunately, you can see in the title, it's not ICU agent. Why I am mentioning this? Because there is a lot of exclusion criteria for using remdesivir. Like multi-organ failure, you cannot use this drug for those patients with inotropic, for creatinine clearance less than 30, for high liver enzymes more than 5 times the upper limit. So there is many exclusion criteria. Plus there is cyclodextrin toxicity possibility, because it's a vehicle they are using to dissolve the drug. So this is another issue we cannot use in the ICU. But if we have it, we will select some patient, of course, to use. But what about the efficacy? Remdesivir is likely to have some clinical benefit. Likely. Why it's likely? Because regarding to this, the biggest study, more than 1,000 patients, they found that time to recovery was better with using of remdesivir, but unfortunately, mortality changes was not statistically significant. So there is no effect on mortality, but time to recovery was better. This is the American study, but for the Chinese study, they studied 237 patients, and there was no change or no improvement with clinical symptoms, and also no change or no difference in mortality rates. Regarding pregnancy, now recently they started to use, and they offering those pregnant women to use the remdesivir as a compassionate use protocol. There is a good chance and a good news that they have some reported cases from Ebola virus trials. There was no harm and fatal toxicity. Unfortunately, for the big study of remdesivir, pregnant women were excluded. Another antiviral, leronavir, ritonavir, we used to use it as a sole therapy, and the clinical data showed there is no rule for this agent to be used as a sole therapy. So we moved to use this one as a part of the triple therapy. Triple therapy, we are using leronavir, ritonavir, but as a sole therapy, we are not using this one. It's a protease inhibitor, but usually we are using this one for HIV infection. As I mentioned, there was no evidence or no difference while it was used alone. So ISCM and Society Critical Care Medicine Surviving Sepsis Campaign, all those suggest against the routine use of leronavir, ritonavir in critically ill adults with COVID-19. What about this agent with the pregnancy? It will cross the placenta and it will cause preterm delivery. It was reported, but there is no increase in the risk of teratogenic effect. One note that you should avoid the oral solution. You can use the tablet. We have the tablet, by the way, and we have oral solution, both of them. But we have to avoid the use of oral solution because it will it causes ethanol as an excipient in the solution. The final recommendation in the MOH guideline or protocol that fetal risk cannot be ruled out, even the lactation, infant risk, fetal risk and infant risk here cannot be ruled out. Viravir, we have it nowadays in MOH, one of our formulary drugs, and we are using for some critical patients, but unfortunately, it's totally contraindicated and teratogenic. So it's totally absolute contraindicated in pregnancy. And even for those male patients, must avoid intercourse for 4 weeks after using this one. A few data regarding to this Asian agent. It was used for non-severe disease with those with oxygen saturation more than 93. And there was a good result by faster rate of viral clearance and more frequent radiographic improvement. But for critically ill patients, we still don't have any data. But as I mentioned, for pregnancy, it's absolute contraindicated. Triple therapy, interferon, ribavirin, leronavir, ritonavir. There was a good study with 127 adults hospitalized patient, but also non-severe. The intervention arm, even triple therapy within 17 days of the symptoms, or dual therapy within 7 to 14 days of the symptoms, versus control with sole therapy, leronavir, ritonavir, and it showed that rapid times to negative nasopharyngeal swab with the triple therapy, clinical improvement was better, and hospital discharge was near than the sole therapy, leronavir, ritonavir. So it was with good results, but again, non-severe cases, and we need more data for critical patients. Also, side effects with the doses we are using, like hemolysis, it was lower in this study and this doses. By the way, we are giving up to 2,000 milligram daily of ribavirin for other indications like hepatitis, but here we are using only 400 milligram BID. Again, regarding to pregnancy, unfortunately, ribavirin is teratogenic, so we cannot use, it's contraindicated. So we cannot use the triple therapy unless we are talking about something like life-saving and multidisciplinary decision, also with the family decision, of course. Interferon, usually we are using for those patients planning until they have the pregnancy. We are stopping the agent, but till now we don't have specific data regarding interferon with COVID-19 and the pregnancy. But in general, because ribavirin is contraindicated, usually I think we cannot use triple therapy, as I mentioned, unless we have a life-threatening issue. Convalescent plasma, there is for those patients, recovered patients, we have antibodies that might help. It's not a new process, by the way, and it was used for Ebola, but unfortunately there was not it was not efficient with Ebola virus, but there is some data that it might be helpful and efficient for COVID-19 patients. We are taking the antibodies and we are measuring the titer of those antibodies. If above the specific number, we can transfer this 200 to 500 ml of the plasma to the infected patients, severely ill infected patients. And they think it might help. But unfortunately, we have a lot of issues with this, mainly logistic issues to finding donors and to confirm neutralizing activity and issues like that. So its use still limited. By the way, we have it here in King Saud Medical City, and we started with 5 patients. Regarding to pregnancy, of the 900 COVID-19 trials already ongoing nowadays, we have less than 2% of those with pregnancy allowance. And you can include pregnant women. Fortunately, regarding convalescent plasma, we have one trial targeting up to 50 patients to be enrolled with the convalescent and remdesivir arms. So, inshallah, hopefully we will find some data regarding convalescent plasma and pregnancy soon. Interleukin 6 pathway inhibitors, this we are using to treat cytokine release syndrome. It's a life-threatening syndrome, so the use of this tocilizumab, which we have it in MOH, it's sometimes is life-saving for those with severe to critical COVID-19 patients. We have other alternative, but I think we don't have it here in Saudi Arabia, like cetuximab. And regarding the pregnancy with this interleukin 6 pathway, we have promising post-marketing data. Still, we cannot rule out the risk of the fetus, but we have some post-marketing data that it was used with some pregnant patients, and there was no reported side or teratogenic effect. There is ongoing studies for COVID-19 patients, but for pregnant, but it's not including pregnant women. Regarding supportive vitamins, as you know, usually we can give multivitamins for pregnant women, but regarding to ICU patients, we are giving very high doses of this vitamin. So we need a clear indication. Regarding the data with COVID-19, we still don't have, but let's take vitamin C for example. Our requirement daily 0.1 gram per day, but we are giving up to 6 grams per day for ICU patients. But we have, to be honest, we have good results. You can see it may reduce length of stay by 7.8%. It may shorten the duration of mechanical ventilation by 18%. But till now, we don't have data related to COVID-19. Our dose from 1 to 6 gram per day. I finished my part regarding the medications, and I want to show you only, I will not go with the details regarding the COVID-19 for a protocol in C1. This is the part of medication only, indications. We have suspected cases. We will give as regular management, and our management will be the same. But with confirmed cases, we will start checking something special regarding, let's say, VTE risk. As mentioned by Dr. Ahmed Madi, we will check the dimer if it's high or low. If it's low, we will go with enoxaparin. Usually, we will modify the doses with COVID positive patients because they have higher risk for VTEs. So, low D-dimer and normal weight, 40 milligram OD or 30 milligram BID can be given. But if we have high weight, more than 100 to 150, 40 milligram BID and 60 milligram BID for more than 151. And if there is renal impairment, you can go with heparin prophylaxis. Usually with pregnant women, we are preferring to use enoxaparin, but if there is 12 hours, we are thinking there will be delivery, so we will shift to unfractionated heparin to reduce the risk of the bleeding, because as I mentioned by doctor, that it has lower half-life, so lower risk of bleeding. Regarding our vitamins, we will start as per the protocol, and mild to moderate we will use hydroxychloroquine if it's necessary, and we will use antiviral after ID approval. For the pneumonia, we can use also antibacterial and antiviral according to the patient risk. This is the all medications we are using with doses, so you only can check that I need to use hydroxychloroquine in this dose immediately. Regarding DVT prophylaxis, I want to show you very fast. Downloads appendix.
Dr. Bashir, we can wrap up.
Yes. Yes, Doctora.
Can we wrap up quickly?
Yes, yes. Well, last slide, almost the last thing I want to. Can you see the? I will check. Okay. Here you can see that we have, if suspected, as usual, you can give DVT prophylaxis. For confirmed cases, we will check risk of bleeding. If there is no risk of bleeding or hit, you can go to the dimer. If it's low, we will give according to the weight, but usually we are using high doses with high weight. If it's high, we will go to higher doses. Sometimes we are going with the treatment, even if there is some symptoms of B or DVT. So if it's high D-dimer more than 1, we are giving 40 milligram BID, and if 100 to 150, 80 milligram BID, so high doses. Even we are using therapeutic if D-dimer more than 3 nowadays. My last slide is that here. Regarding to sepsis, something also very common with COVID-19 patients, especially the length of stay is usually prolonged for those critical patients. Here you can find the safe medication you can use with sepsis and the pregnant women. You can use Metroclinda, Beptazo, and gentamicin with the coverage. This is for sepsis management. This is antibacterial management. And thank you very much. Thank you for having me.
Thank you, Dr. Bashir, for your detailed talk.
Thank you, Doctor.
Any questions, they can be in the chat box, so we can answer in the chat box. I would like to thank Dr. Ahmed Kuhail and Dr. Gultakia, who are the co-directors of this course, and our GEMS, Christine and Emiliana, who are the course coordinators. It was not possible to have this course arranged without their effort. With ongoing duties and busy schedule, it was really difficult to get into this routine. And I know we are already running very late, but I'm happy tomorrow is Friday. And so this is the last lecture. I will like to see teacher in concentration. This is the message. And I will try to quickly finish my 15 to 20 minutes, inshallah. So my slides are clear?
Yes, Doctor. Clear.
Okay. So as you know, we are in the pandemic with COVID-19, and there were interim guidelines released by American Heart Association as well as European Society of Resuscitation regarding the specification which we should apply in patients with COVID-19 in context with the cardiopulmonary resuscitation. So my topic today is dealing with CPR dynamics, particularly in the pregnant women uh, who are suspected or confirmed COVID-19. And by the end of this lecture, I wish we'll be able to go quickly through the advanced cardiac life support guidelines for maternal cardiac arrest as endorsed by American Heart Association, and we'll be able to have the understanding of team dynamics as well as the role of team leader and team members. And we'll go through the precautions and the guidelines for CPR in COVID-19 patients with specific considerations for COVID pregnant patients. And also I would like to touch the topic of perimortem cesarean delivery, when it should be considered and why it is important. All of you must be aware and familiar with this slide. Yes, I'm going to talk about the chain of survival. And as you all know, these are internationally recognized standard of early interventions, which gives the victim of sudden cardiac arrest the best chances of survival if implemented early. So these are basically 5 events that must occur rapidly in an integrated manner during the cardiac arrest, which includes early recognition and activation with the early initiation of high quality CPR, rapid defibrillation, and advanced life support, followed by the post-arrest care. And as we know, all of these are interlinked in the chain of survival. Once we talk about high quality CPR, there are 5 important components of high quality CPR as endorsed by American Heart Association. As you all know, we always say push hard and push fast. So at a rate of at least 100 to 120 compressions per minute and a depth of more than 5 centimeter, which is approximate more than 1/3 of anterior posterior diameter of the chest, allowing for the full chest recoil in between the compressions and minimal interruptions and with adequate ventilation. And we have to avoid over ventilation and not to overemphasize, like we have to check for the pulse and to rotate the compressor every 2 minutes, and it can be done early if they are fatigued. As you all know, teamwork always makes the dream work. And a successful team is a group of many hands and one mind. And mostly successful teams, they are not only the expert for the medical experience and the mastery of resuscitation skill, but they also demonstrate effective communication and team dynamics. So once we will be having any patient who is coded, will be asked, like the primary responder will be the team leader. And what we want from the team leader, good situational awareness. Like they should pay attention to whatever is going around and not to fix on one problem. And the team leader is a very important component of the team, will organize the team, monitor the individual performances of the member, is a backup for the team members, is a model for excellent behavior, and is involved in training and coaching as well as facilitates the understanding. While we are a member of the team, we must respect their authority and should be prepared to carry out the instructions of the leader. And always the poor leadership will induce frustration, anxiety, and have a negative impact on the team as well as its future performance. Sorry for this interruption. I hope my slides are clear.
Yes, it's clear now.
Yeah, okay. So as a team leader, we should have good situational awareness. But if we move to the role of the team members, they should have complete focus on their individual tasks. Like a team leader is focusing on the comprehensive patient care. So the team member, they must be clear about their role assignment, should be ready to fulfill their role, responsibilities. They are well practiced in the resuscitation skills and knowledgeable about the algorithms, and they are committed to success as a team. And once we say about effective team dynamics, we refer to the forces, the operating forces which are present within the team. And you all must be aware we are talking about closed loop communication, clear messages, clear roles and responsibilities, knowing the limitations, knowledge sharing, constructive interventions, re-evaluation, summarizing, and mutual respect. As you all know, once we are talking about effective dynamics, we mean communication. And effective communication is a very important component of the successful team. And once we speak about effective communication, we mean closed loop communication. And closed loop, you must all be aware to have a task done by the member. He will ask it, but which he will reconfirm by asking and will perform the task and acknowledge back to the team leader. So this is known as a closed loop communication. To listen, to understand, and to talk back. It reduces the error by removing the ambiguities, and it allows for the question if the instruction was not heard clearly. Also, the role of clear messages is very important. As a team leader, we must deliver the messages in clear, consistent tone, in a calm and direct manner without yelling, shouting, or being angry. As you all know, the unclear communication will lead to delay in the treatment or to the medication errors. Similarly, the clear roles and responsibilities, they should be delegated at the beginning of the cardiopulmonary resuscitation by the team leader. And why it is important? Because if there are no clear roles, multiple members of the team, they may perform the same task more than once, and they miss the essential task, and it will lead to the freelancing of the team members. To avoid such sort of inefficiencies and ineffective team dynamics, the team leader must clearly delegate the task. And if he is unsure about their responsibilities, it's better not to assign. And if the team leader wants additional help, additional responsibilities by the member of the team, he must communicate with the team members and take them into the confidence. As you can see on the slide, it is a picture which is depicting dynamics for the CPR. Here we can see there are like 6 members of the team along with the team leader. So the team leader is there. One is responsible for the airway and breathing. One member is responsible for the compression, and the other responsible for the defibrillation, as well as will rotate with the first compressor. One of the nurses is responsible for the vascular access along with the medication, and the other is responsible for documentation. But as we are talking about the pandemic of COVID-19, all the recommendations, they are favoring and supporting for safety of the healthcare workers. So the recommendation is to reduce the number to minimum which are required for the procedure or required to carry out any particular task. So minimum number can be reduced to even 4 in order to avoid the contamination and safety risk for the healthcare worker. You must all be familiar with these all components of the team dynamic. As we are all getting late, I will try to go quick with the specific topic of CPR in the pregnant patient. As you all know, while we are discussing with maternal cardiac arrest, there are some specifications, some considerations which must be taken into account. And as everybody is aware, the maternal resuscitation, it is an acute event, and it involves many subspecialties as well as different variety of the healthcare workers. And also the cardiac arrest in pregnancy, it is one of the most challenging clinical scenarios. Although most of the features of the pregnant woman resuscitation, they are similar to the standard adult resuscitation, but still there are some considerations which are uniquely different. So we'll try to focus on those, and the caregivers, they must understand the maternal physiology, and they must be well equipped, because the knowledge gap and the loss of understanding of the physiology, it will lead to errors, and it will lead to increase in the maternal mortality. As we all know, and very good description was given by my colleague Dr. Waleed regarding the airway and the ventilation considerations for the pregnant lady. Here it is more or less the same. I will just recapitulate, like they have decreased tolerance for hypoxia and apnea, and we have to consider the swelling and edema of the airways, including the friability of the mucosa, and it may be a difficult mask ventilation scenario because of low functional residual capacity, elevated diaphragm, and raised intra-abdominal pressure, and the weight gain, obesity, adding the risk, and the Mallampati classification may go even higher, and there is increased risk of aspiration due to delayed gastric emptying, as well as lower tone of the lower esophageal sphincter. So while we are addressing this issue of maternal cardiac arrest, I would like to emphasize on the interventions which we can use to prevent the cardiac arrest. So it is very important to recognize those patients early who are at the risk of sudden deterioration and sudden cardiac arrest, and to apply the intervention early in this group of patients, to mobilize them to the area with appropriate expertise, appropriate level of care which can be given to them in order to avoid unprotected and unexpected cardiac arrest for these patients. Like if we are facing any patient who is at the risk, it's better to place the patient in the full left lateral position to relieve the possible compression of inferior vena cava. As we all know, uterine obstruction of venous return, it can produce hypotension and will precipitate the arrest in the critically ill patient. Similarly, to provide 100% oxygen for these patients, to establish the IV access, preferably above the diaphragm, because again, the consideration of compression of the inferior vena cava by the gravid uterus, which may make the vascular access inefficient if it is the femoral or the saphenous vein. And we have to assess for the hypotension, and maternal hypotension can result in reduced uteroplacental perfusion. And the patient who is not in arrest, both the crystallite and the colloids, they can be used to increase the preload. And we have to always consider reversible causes of critical illness, and we have to treat the conditions that may contribute to clinical deterioration as early as possible. If we go briefly through the sequence of CPR in the pregnant patient, I would like to emphasize for intubation early. As we discussed before, they have very low threshold for and tolerance for apnea. We have to protect vulnerable airway with supply the oxygen, tilt the patient, and better if rather than tilting, if we use manual left uterine displacement. As we know already, if we are tilting the patient, this was practiced like up to 30-degree tilt. It will decrease the pressure on the vena cava. But at the same time, if the patient who is sick and who is arrested and you are doing the compression forces, they will be reduced. It's already the closed chest CPR, we are able to produce at least 30% of the cardiac output by the compressions. But if the patient is still having compromised venous return, the cardiac output may decrease further by 30 to 50%, which will lead to further deterioration of the clinical condition of the patient. But if we apply manual left uterine displacement, we can still continue with all the precautions and the measures which we use for any other arrested patient in the supine position, and to make sure the efficacy of the chest compression will be the same, and it will be better if rather than if we use the tilting position. And it has been shown that if the tilt is more than 30 degree,
it may cause worsening of the vena cava compression. And we have to obtain the IV access, as I told before, avoid femoral and the saphenous vein, follow the ACLS algorithms as per the HA or even RCUK, and perimortem cesarean, it should be considered within 5 minutes of maternal cardiac arrest if the fetus was more than 20 weeks of gestation age. Consider for open chest CPR within 15 minutes of maternal arrest. And we have to explore the differential diagnosis, and we have to see for the iatrogenic causes like spinal analgesia with local anesthetic complication, and consider for even cardiopulmonary bypass and extracorporeal CPR if it is indicated. So if we go with the particular modification of cardiopulmonary resuscitation, the most important thing to remember is the positioning. As I told before, if the pregnant uterus, especially more than 20-week gestation, which is, or the gravid uterus is palpated above the umbilicus, it will compress the inferior vena cava, it will impede the venous return, therefore reducing the stroke volume and the cardiac output. So in order to improve the quality of the CPR and resultant compression forces and output, it is better to put the patient in the left lateral tilt or with manual uterine displacement, as we told. In non-cardiac arrest, parturiente still left lateral position, it has shown improved maternal hemodynamics regarding blood pressure, cardiac output, stroke volume, and even the fetal parameters of oxygenation and heart rate, they improve. So this is the picture where you can see the left lateral tilt with 30-degree. If we go with the manual left uterine displacement, it could be by the two manuals. If we are on the left side of the patient, we use the two-handed technique with cupping the uterus by two hands and pushing up and towards left. And if it's on the right side, we can use the one-handed technique. It will depend upon the position of the resuscitation team. And if chest compression, they remain still inadequate after both left uterine displacement or left lateral tilt, in emergent cesarean section, it should be considered in this patient population. Regarding the chest compressions, as well as the medication and the defibrillation, there is not much difference between the pregnant and the non-pregnant population. For previously, there was some recommendation to use a higher position on the chest, but there is no scientific evidence supporting it. And currently, the same position as in the non-pregnant lady, the lower end of the sternum, the middle of the chest is the place where we should be applying the chest compressions. There is no role of manual chest compressions as it is being advocated in this COVID-19 pandemic, particularly for the adult patients who are appropriate according to the weight and the criteria. But in the pregnant lady, there have been no studies and it is even not recommended. So if we move towards the defibrillation, it is not a risk for the fetus. The defibrillation, same energy like we are giving for the non-pregnant can be given to the pregnant patient. But we have to be careful to remove all the leads and the fetal monitors, external or internal, in order to avoid electrocution. And it is not a harm for the fetus. So regarding perimortem cesarean delivery, it has been indicated the aim for incision is by 4 minutes and aim for delivery is by the 5 minutes. It has been shown that the decision when to consider the perimortem cesarean, who will be the decision maker? It is a very important question, and as we believe, whenever there is maternal code announced, it is teamwork which is consisting of the obstetrician as well as the neonatal resuscitation team along with anesthesia or intensivist. So basically there is not a single leader. There are basically 3 team leaders for this maternal code. ICU or anesthesia is taking care with the resuscitation, but regarding the decision making for perimortem cesarean as well as neonatal resuscitation, it will come as a result of combined discussion between the team, particularly the obstetrician as well as neonatologist. So whenever the decision is taken, particularly the patient who is having 20 weeks gestational age or uterus is palpable above the umbilicus, perimortem cesarean delivery is considered, it is very important to actively prepare for expedited delivery as soon as arrest is confirmed. And we have to continue CPR throughout with the left uterine displacement. So there will be like two teams. One will be continuing the CPR and maintaining the left uterine displacement, and at the same time, perimortem cesarean will be conducted at the same place without transferring the patient either to the OR or the labor room. So why it is very important to consider perimortem cesarean in cases where it is indicated? Because it will help with the cardiovascular and respiratory functions for the mother. Because during the arrest, the priority is the mother. As we know that the normal CPR, it is producing only 30% of the cardiac output, which is further decreased to 30 and below 50% with the supine position. And as soon as aortocaval compression is released, it will increase the venous return and it will improve the cardiac output, so improving the maternal outcome. Similarly, it will help in improving the ventilation and will decrease the oxygen consumption as well as decrease the carbon dioxide production for the these patients. So this is a very important slide, and it is important to remember alive at 5. So whenever there is a maternal cardiac arrest, there are some steps which should be followed. So we have to activate the maternal code, and at the same time, we will start the timer. And we have to go for left uterine displacement, intubate early, IV line securement above the diaphragm, verify the team, equipment for the delivery, and extract the fetus. So it should all occur within the time frame of 5 minutes. So ideal is the incision by 4 minutes, and the baby should be extracted by the 5 minutes. Again, I will emphasize the things which we should avoid in the maternal cardiac arrest. Do not focus on the fetal heart rate or tracings or the status until the ROSC is achieved. Remove the monitors for the fetal monitoring during resuscitation in order to expedite the access for perimortem cesarean delivery. Do not delay in moving towards PMCD when indicated. Do not move the patient to perform the cesarean to either OR or labor room, as I told before, and do not wait for the surgical equipments and lengthy antiseptic procedure. It just requires a scalpel and the gloves. It has been shown that perimortem cesarean delivery, the outcomes will depend upon the underlying etiology, the cause of arrest, maternal pathology, as well as cardiac functions, and the gestational age, as well as the resources. It has been shown that pregnant patients, they may be more salvageable, and 58% maternal survival has been observed in these patients. Neonatal survival basically is related with the time to cesarean. If it is performed with less than 5 minutes or into arrest, it is 96%. And if it is more than 5 minutes, it reaches up to 70%. But still here, there are other factors also which are affecting the chances of survival for the fetus, like short interval between the arrest and the cesarean. If there was no sustained pre-arrest hypoxia for the mother, there were minimal or no signs of fetal distress before the arrest, or aggressive and effective resuscitation was done for the mother, it will improve the outcome. Also, the procedure is performed in the centers where there is facility for the neonatal ICU is available, along with the resources, and as well as the operator's skill and experience in doing such emergency cesarean sections. So these were some basic considerations while we are dealing with the maternal cardiac arrest. Now my talk will be focused with the algorithms and the changes in the resuscitation related to the COVID-19. So I will try to summarize it and will make it easy. As you can see, the slide is showing the algorithm which was released by Resuscitation Council of UK. As these were interim guidelines which was released in 27th of March. And it was followed by interim guidelines by the American Heart Association. More or less, both are the same. But I found it very interesting because it is also not explaining the phases of the cardiac arrest resuscitation, but also guiding us about the type of PPE which we should be wearing while we are dealing with the COVID-19 patients. So the first phase here, it is basically dealing with the conversations, decisions, emergency management, and treatment escalation plannings. And they want it to be very clearly decided and documented and individualized. And all the members of the team, they must be aware about the treatment plan for the patient. And it is very important because it will avoid any unexpected, unprotected CPR and unexpected exposure of the healthcare worker to the COVID patients without the proper PPE. So if any patient is found arrested, unresponsive, not breathing normally, we have to activate the resuscitation team. We have to state maternal code as well as state the COVID-19 status for the patient. We have to assess the rhythm. If it is shockable or a non-shockable rhythm. So if you see on the left side of the slide, here are mentioned the phases: phase 1, phase 2, phase 3. So phase 3 is basically dealing with aerosol generating procedure. And as by now you must be aware that airway interventions and chest compressions, these are the aerosol generating procedures. So it must always be done with the level 3 of PPE, which include disposable gloves, gown, filtering face piece or respirator, and disposable eye protection. Until unless you are not having appropriate PPE for aerosol generating procedure, you are not supposed to do any chest compressions or any airway interventions. So what we can offer is the shock. Any patient who has a shockable rhythm, VF, pulseless VT, we can shock the patient because the shock and the assessment of the pulse, these are not aerosol generating, and they can be done in the level 2 of PPE, which include disposable glove, gown, and fluid resistant surgical mask and disposable eye protection. So here we can shock the patient, and we can shock even up to 3 times maximum till our help will arrive in appropriate PPE for aerosol generating procedure, and they can take over the CPR. But if it is a non-shockable rhythm, then you have to go and don the PPE or wait for the help to arrive with appropriate PPE before we continue with the chest compressions. And when there is a return of spontaneous circulation, we have to follow the same algorithm like we are doing for according to the AHA guidelines, and we have to maintain ABCD approach, normal oxygenation for these patients, aiming for normal CO2 with a 12-lead ECG, look for the causes, and appropriate intervention if needed will continue. And there have been consideration about the use of ultrasound imaging. As I told, mechanical compressions, these are not indicated for the pregnant. They have not been tested and not recommended still because it increases the chances of, it is causing more damage with trauma rather than helping the patients, particularly in the pregnant population. And coronary angiography and EPCI, if indicated, we should do, and extracorporeal CPR, if indicated, it can be carried out. So here I will still emphasize about resuscitation of COVID-19 patients in the hospital regarding the treatment escalation and resuscitation decisions. It must be very properly documented and it should be properly communicated. So once you recognize the cardiac arrest, what you have to do maximum, you can feel the pulse. You are not supposed to put your face near the patient face to listen or feel for breathing. Call for help, state the COVID-19 risk. This is very, very important. So the team which is coming for help will be in the proper PPE for aerosol generating procedure. It will save the time. Meanwhile, what you can do, you will attach the defibrillator and shock if it is indicated. It has been shown early restoration of circulation. It may even negate the need for the chest compression and ventilation. Once you have done with the proper PPE, you can continue with the chest compressions. So it is very clear by now, there are no chest compression or no airway procedures until you are in appropriate PPE. If patient is not intubated, was on oxygen with a face mask, leave the face mask and continue with the compression only CPR. And you have to restrict the number of the staff. So here again, the safety of the healthcare worker is a priority and it is emphasized again. You have to secure the airway by the most experienced and competent member of the team. As Dr. Waleed explained it very clearly, It should be the most competent member to decrease the number of attempts, decrease the aerosolization risk, particularly if available by video-assisted laryngoscopy. And once the patient intubated, attach the viral filter and maintain a closed circuit, avoid any discontinuation of the circuit in order to protect the health workers again. So we have to go back with the HNTs of the cardiac arrest, the reversible causes. We have to look for it and dispose of or clean all the equipments which are used during the CPR. But in maternal cardiac arrest, along with the HNTs, very important thing you have to look is specific causes which are related to the maternal cardiac arrest. You can remember it by the mnemonic of Bew chops. So B is for bleeding, hemorrhage, and DIC. E is for embolism, which can be pulmonary or the amniotic fluid embolism and coronary embolism. You have to go for anesthetic complications. U is for uterine atony. It could be cardiac disease like MI, ischemia, aortic dissection, cardiomyopathy, hypertension like eclampsia, preeclampsia, and other causes which are the standards, the differential diagnosis in ACLS, as I told before, H and the T's. And we have to see for the placental abruption and placenta previa as well as the sepsis. So it is very important to remember these causes related with the maternal cardiac arrest while we are dealing with the maternal code, in addition to the H and the T's which we follow with the ACLS algorithm. Always remember to remove your PPE safely, avoid self-contamination, and dispose of in clinical waste bags as per the infection control recommendation, and perform the hand hygiene, and always go for the post-resuscitation debriefing to improve the practices and to improve the outcome in the future maternal cardiac arrest. So if you go with the summarizing quickly, the general principles for resuscitation in suspected and confirmed COVID-19, there are three basic principles. So you have to reduce provider exposure risk to COVID-19. You have to prioritize oxygenation and ventilation strategies with low aerosolization risk. And we have to consider the appropriateness of starting and continuing the resuscitation. So the very clear message, how to reduce the risk, as I told before, appropriate PPE before entering the room, limit the number of the staff who are present at the time of the arrest to minimum, prevent airborne contamination of the adjacent indoor. So keep the door closed always. Devices, it can be used in the non-pregnant patients, but in the pregnant maternal COVID, we are not going to use the mechanical compression devices. We have to proactively scrutinize those patients who are at the risk of sudden acute deterioration or unexpected arrest to bring them to the appropriate care and the level of protection as well as the level of appropriate expertise where they can be managed properly. So moving them early to specialized areas, and always mention the status of the COVID-19 to any new person who is arriving at the scene. And ideally, we should limit the number who will enter into the area where the maternal code is being conducted. So regarding the ventilation strategies, a patient, if it's intubated, leave the patient on mechanical ventilator, connect the HEPA filter, maintain the closed circuit, and reduce aerosolization. And adjust the ventilator settings while increasing the FiO2 to 100%, assist control mode, keeping the tidal volume 6 ml per kg and the rate of 10 to avoid over ventilating these patients, and to adjust the trigger to off. If the patient is not intubated and we believe it will be delayed, so we have to keep the non-rebreather face mask with 50 liter oxygen even, and continue with the compression only CPR, or we can apply manual ventilation with back valve mask with appropriate precautions, and LMA can be inserted if available, and do not forget the HEPA filter. So we are approaching the final slides. I will still emphasize, and this will be the take-home message, which I believe for all of you, to make sure the conversations and treatment escalation planning must be prioritized, individualized, and ensure the multidisciplinary decisions, they are well documented and communicated, and identify early of suspected and confirmed COVID-19 pregnant patients who are at the risk of acute deterioration or cardiac arrest. And thank you for listening. I hope this lecture is going to help in any maternal cardiac arrest if we face in near future. I would like to thank all of you for joining with us for this online course for COVID-19 in pregnancy. And special thanks to all my faculty members, along with the course coordinators, as well as my course co-directors. It wasn't possible without your active participation. And we'll soon be having another online course, which is basically designed for non-ICU physicians. And it is more detailed. It is covering all the aspects for the COVID, including the ventilation, hemodynamics, and kidney failure, multi-organ involvement, along with the pathophysiology. It is not. It is very wide. So anyone who is interested to learn more about the COVID and how we are managing it, are warmly welcome to contact with us, and they can communicate with Christine, and she will help in registration and to make it easy for all of you.
Yes, so this is Dr. Shahzad with you, and thank you very much from the faculty. And I think my comment will be the second last. After that, I will ask Dr. Hazmi that to give the final comment. Thank you very much for listening. In the last comments, just I will say sorry that it has been 40 minutes late, but I was thinking that Saima lecture will be great to listen, and the people were listening keenly. Thank you very much, Dr. Gultakeen and Ahmed Kohel. They're the course directors, and they were sitting with us since many days, and they arranged very well. And thank you very much for Christine and Emilia. Christine is the one who will be contacting all of you for the course certificates. And as Dr. Madi told, that sooner if we have the registration for CME hours, this course participants will be granted CME hours as well. Give us the feedback, what you have feel to Dr. Saima and Dr. Aisha. Thank you very much all. And I will give the final comments to Dr. Hussain Al-Hazmi. He will give, and after that we will leave the session, inshallah.
Thank you everybody for this wonderful course. Actually, the management of pregnant lady with COVID is a challenging due to the physiological change of pregnancy, due to we are managing two lives. There is a lot of area for conflict, the area of termination of pregnancy, the area of early intervention, and so on. I think you covered the whole subject in nice manner, and we need also another course for updating. Thank you, everybody.
Thank you very much, Dr. Hazmi. And Dr. Ahmed Kohel, should we leave and you will end the course? Ahmed? Dr. Ahmed Kohel? Actually, we were having a lot of participants. The room was full of 100 participants at one moment, and then we were on the YouTube as well. So thank you very much, all the participants and faculty, and see you, inshallah, as Dr. Hazmi told, if we are able to arrange another one with the good participants, inshallah, see you again, inshallah. Thank you very much. Allah Hafiz. Assalamu alaikum. Good night.